Morning, everyone. Today is the day that I, Dr. Radhika, with my colleagues Dr. Mugdha and Dr. Harshini, will cherish the rest of our lives as we have been given the exciting task of welcoming all of you and being the anchor for this day. We are delighted, privileged to meet, greet, and mingle with all of you, our distinguished leaders, teachers, colleagues, and friends who will lead and teach all of us the many mysteries and realities of thyroid cancers.
Today we are celebrating the second anniversary of our revered institute, the HNCII. Our goal today will be to dive deep into the oncological characteristics of the thyroid. When it comes to thyroid, it is never a one-man show. We need inputs and help from every available discipline in the oncological practice, be it from radiology, pathology, endocrinology, nuclear medicine, biochemistry, speech and swallow therapists, medical and radiation oncologists, and of course, surgeons too. In the light of this shared responsibility, today's theme is titled, If It's Thyroid, All Hands on Deck.
Throughout the day, we all will be flooded with loads of information and clinical scenarios which will force us to think, ponder, and get us all fired up in this stimulating quest of knowledge. An academic feast awaits you all. Welcome, everyone. Enjoy our hospitality and the exhilarating scientific sessions of the day.
Light or roshni, it brings hope and joy. As Indians, we value our tradition of lighting the lamps, as it indicates purity and it represents the triumphs of knowledge over ignorance, hope over despair, and light over darkness. For this sacred ceremony, we invite Dr. Pradhan, Dr. Ashok Shaha, Dr. Farokh Udwadia, Mr. Yes.G. Malegam, Dr. Avinash Phadke to come on the dais to please take us into the brighter world. As we invoke positivity and harmony for this occasion, we invite our nursing staff, Bhavna, Swapna, and Siddhita, for a prayer song.
ज्योते परब्रह्म दीपक ज्योते जनार्दनः दीपक ज्योते परब्रह्म दीपक ज्योते जनार्दनः दीपो हर्तुमे पापं सन्ध्यादीप नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरमव्यः हो दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरमव्यः आरोग्यं देहि पुत्राक्ष पति स्वेच्छा हि मे सदा शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः. Thank you.
Thank you. We now call our respected Dr. Pradhan sir, who is hardworking and soft-spoken chairman of HNCII, to address the audience with some opening remarks and share some of his pearls of wisdom. His passion and dedication to work is legendary. We request you to kindly come on the dais, sir.
Good morning and a warm welcome to you all. It has been an eventful 2-year period. A lot of the dreams that I dreamed of have started to materialize, and some didn't. But today I will only reflect on the brighter side and reflect on those where we have really been very fortunate and have done well. First and foremost amongst that is that we have outstanding leaders in every medical department. Dr. Roshan Chinoy, Dr. Tapan Saikia, Dr. Rajan Kannan, Dr. Sharmila Agarwal, Dr. Asif Momin, Dr. Dilip Deshpande. They've all had they have such high reputation in their field, and they provide such leadership, credibility, and they really reinforce the ethos of the institute. But most importantly, they have been able to attract good young talent. And it is this young talent, the Ketan and Netra, the Kannav, Karthik and Mohsin, Yasha, Vibhavari, Prashant. Every department we've had such wonderful people. And they seem to tell me when I look at them, don't you worry. We are here. We will lead and we will succeed. That's a very reassuring thought that I have. Even in the nursing department, to have Sister Sine with us, an outstanding leader. Nursing is such an important aspect of healthcare. In the admin department, Reshma is very blessed to have a wonderful team led by Dr. Yogesh Agarwal. And the way he addresses all the systems and processes that need to be built in is something that you can learn from. These are things that are not easily seen, but if they don't exist, then you will falter. The institution will falter. So we're very fortunate in having all this with us. Like laryngeal cancer last year, we decided to have thyroid cancer as the theme for today's conference. Much progress has occurred in this field, and it needs to be communicated to the youngsters. And I'm very, very fortunate that my friend Dr. Ashok Shah agreed to come all the way from New York to deliver the hospital's second oration. I'm also very grateful to Dr. Farokh Udwadia, the doyen of ICU care in India, to agree to come as a guest speaker and share his wisdom. Any tertiary care center will need an intensive care, and Dr. Farokh Udwadia, who better than Dr. Farokh Udwadia to learn from? I'm grateful to Prathamesh for heading one of the panel discussions that we will have, and all the panelists who have agreed to participate and share their expertise. Most of all, I'm grateful to all of you, to the visitors, to the delegates, to come and grace the occasion here and make this into a lively, meaningful second anniversary. I will request my friend and colleague for 40 years, Dr. Rajan Kannan, the Chief of Surgical Oncology here, one of the finest surgeons that I have seen, to come and introduce the orator of the day, Dr. Ashok Shah.
Good morning. Should I say Dr. Ashok Shah, Professor Ashok Shah, or Grandmaster Ashok Shah? He's one of the pioneers of head and neck surgery, works at Memorial Sloan Kettering Hospital, Cornell University, New York. If you Google his name, there are 50,009 citations, 610 papers, and he's out of the world. He started his medical career in Baroda in 1975, and then MSKCC, and then became a professor there. And he's been actively involved in training medical students at the Cornell University and Advanced Training Council for Head and Neck Oncology Fellowships in the USA for 10 years, and Distinguished Service Award by the Head and Neck Society twice. Now, he's very, very useful to our institution, where he's taken classes for every Saturday evening at 5 o'clock in the evening for the last few months, which is 5 o'clock in the morning in US. And our students are talking, oh, this fellow, he's got clubbing and he's vegetarian diet and so many things, all this violent history. And then he'll just pick up the nub and the crux and giving his wisdom. And in the last class, I was really happy. He spoke about T5. T5 in cancer is the advanced operable cancer, but is it worth operating? It's such violent surgery which will leave the man disabled. I introduce you, Professor Shah.
Thank you very much. That was the kindest introduction I had had. So I wish my wife was here, to listen to this. Better yet, wish my young son was here, because he thinks I know nothing about computers. I'm not genius. I know nothing about Google. All that I know is how to operate. So I think there is a difference. So what I'm going to do in next 45 minutes or so, take you through some controversies and subject of controversy in thyroid cancer. Can you bring my slide? So the topic I have chosen is completion thyroidectomy, Circa 1992. And the reason I have chosen this topic is this has generated a lot of debate, a lot of controversy in the management of thyroid cancer. As you know very well, the incidence of thyroid cancer is rapidly rising around the world. It's probably the most common cancer we see in women in the United States. And probably in South Korea, in last 10 years, the rise has been almost 15-fold. Why? Because we are trying to find more cancers. This was the same thing that happened about 15 years back. Everybody was getting PSA. So the incidence of prostate cancer went through the roof. Was that there before? Yes, it was there. We just didn't identify it. Now we identify it and we are creating our own problem. But as we discuss about the management of thyroid cancer, I think it generates a lot of debate, a lot of controversy. What do you do when you have taken one lobe out? Do you go back and do the second operation? So coming to Bombay, I still use the word Bombay. You know, I was brought up in Bombay, so it is going to take some time to change it to Mumbai, but I think I'm trying my hard. So the Queen of Malwa, Ahilyabai Holkar, my wife and me, we used to watch that series, you know, and it was wonderful, you know. And for the first time, I realized 300 years back, the women were so advanced in India. And many of you probably don't know, there is a new coin of 300 rupees in India. This was celebrated by the Prime Minister very recently. I was amazed. And I think it is very important for us to recognize the people who have contributed immensely, whatever, politics, science, or anything else. So I do commend her for all her contributions. And what is interesting is, this is she was an inspiration to those who wish to have big dreams in life and hard to pursue them. I think that is very important. Two things are very important, the dreams and the way we pursue them. And I think there is nobody else in this audience who has achieved this so much as my good friend Sultan Pradhan. I think he has done an amazing job for the cause of head and neck cancer in India for the past almost 45 years. And we were fellows together at Tata, and I still remember how he treated not only the patients, but the colleagues gently, patiently, with enormous respect. So there are a lot of things that we can learn from him. I have to give a talk, so I cannot speak for the whole hour about you, but Sultan, I congratulate you for what you have done. It is very interesting, you know, whenever you give a talk in a national meeting, international meeting, there are certain slides which are very constant, you know, they don't change. The first slide is the institution you come from. This is the Sloan Kettering, the old building, probably many of you remember that. This is the new outpatient surgery center, and this is the clinic that we built. Somebody was very kind, David Koch, to donate $500 million. Anytime you get the money from anybody, the first thing you do is how to build a new building. Because that's where the genesis is. That's where you can progress. So this is our new clinic building, very nicely done, architectural marvel. If you come to New York, please do visit it. There is one other place where you may want to go if you come to New York, and that is the Freedom Tower. I think the Freedom Tower, if you cannot leave New York now without seeing Freedom Tower. It's beautiful, architectural marvel, and more importantly, when you go on the top of the building, the emotions you get is just unbelievable. So I wanted to talk about completion thyroidectomy, a critical appraisal. I wrote this paper back in 1992, exactly 33 years back. And I'm using that article just to recapitulate that if you know the biology of cancer, everything is very easy. Whether it is tongue cancer, whether it is larynx cancer, if you know the biology and you know how the tumor progresses, everything is very simple. So this was a paper that I wrote. It was my passion. I just wanted to write something from my heart. And I wrote this paper, Completion Thyroidectomy, a Critical Appraisal, because there was a lot of debate in the United States whether about total thyroidectomy or lobectomy. And we have been fighting about it for last 50 years. We'll continue to fight about it for another 50 years. But what has changed is now everybody understands the biology of thyroid cancer and the outcome, which is outstanding. What is more important is to identify which patient is not going to do well and be more aggressive for that patient. If you get a T1 tongue cancer, you know that patient is going to do very well. Yes, you do need to invest time and energy, but the multimodality treatment comes for advanced cancers, whether it is a tongue cancer, larynx cancer, or thyroid cancer. You can go back. They don't want to see me all the time. Okay, so this was the paper that I wrote, and the message was the minimal operation for thyroid cancer is a lobectomy. And take it from me, the maximum operation is still the lobectomy. And I think if you look at the ATA guidelines, which have really made an enormous progress around the world and impact around the world, they have come to the philosophy that Memorial has been practicing. When we saw these new guidelines in 2015, we were making fun of each other, that we have been practicing the same guidelines since 1950. We have not changed at Memorial. Our philosophy has not changed. We understood the thyroid cancer very well. And that's why I call this diagnostic and therapeutic lobectomy. If you have a thyroid mass, you don't know what it is, you want to take care of the patient, just do a lobectomy, and majority of the time, 95% of the time, that's the most operation you need to do. So I wrote this, whenever you write a paper, you need to come up with the algorithm. This was the algorithm I developed. Believe me, nothing has changed in 50 years. We wrote a lot of new papers. We write papers every day. It is the same paper that we write again and again. But this was the algorithm that I developed that time. And now the American Thyroid Association practically has copied the whole philosophy. It has not changed, the same philosophy. So when we talk about completion thyroidectomy, there are different names: stage thyroidectomy, completion, two-step thyroidectomy, sequential thyroidectomy, stepwise thyroidectomy. At Memorial, we call it Shaha's thyroidectomy. We have to have our name. The greatest joy in life is when you see your name on a paper. That is number one. And when somebody else quotes your paper, you feel the great joy. There's absolutely no doubt about that. So William Hazlitt made a mention, when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. If you want to go ahead in medicine, take a controversial subject, and you will succeed in that. The greatest controversy is the management of common cold. And my grandmother used to say, if you treat common cold, it stays for a week. If you don't treat it, it stays for 7 days. I just feel sorry. She should have gotten a Nobel Prize for that one statement, amazing. Okay, why there is a debate? And I think if you go back in medicine, there is a debate when the outcome is the same. There is no debate what will happen if I jump from this window. Everybody knows that, right? But there is a debate what will happen if I fall on the stage here. So the debate comes because the outcome is the same. And we are trying to, what I think Dr. Pradhan made a mention, what we are trying to do is to get the best outcome and the best functional rewards. You have a patient, let's say oral cancer, cannot speak, cannot eat. I don't think we have done a service to the patient. And the new advances that we have developed, multimodal treatment, that pays attention to the functional outcome. And I think this is very, very critical. So the results are equally good, whether you do a lobectomy or total thyroidectomy. I won't go in the details of this, but one thing we are trying to learn now and trying to employ is the quality of life of patients undergoing thyroid surgery. It's very important. And that quality of life has been little bit extended now to avoid a cut in the neck. I don't think any American woman or any woman minds a cut in the neck. It looks good. You know, you put a nice cut, do the nice closure, plastic closure, they look very good. Actually, majority of the women with thyroid surgery, they try to show off. Look, my cut looks so good, you know. And I think they are very happy about it. So the quality of life plays an important role today in the management of all cancers, especially in thyroid cancer. Now, this is one of my favorite slides, you know. I use this all the time. I update it every year. In last 10 years, there are 61,000 publications on thyroid, out of which there are about 30,000 are on thyroid cancer. It's the same paper we write again and again. You think I have written anything new? No. It's the same language, change the language. For me in America, it is very good because I can write once in Hindi and once in English. So for me, it is very, very beneficial. If you look at analyze the data, every 3 hours there is one new paper on thyroid cancer in the literature. Now this is perfectly okay. We always do this because I want to become professor, and the only way I can become professor is write 3 more papers. But take a look at the Google search. There are 62 million sites. And my son is great, you know, he is great with the computers, and he told me, Dad, if you want to read these 62 million sites, it will take you 330 years. He told me you have to be born 5 times and still you won't finish, because by the time you are born 5 times and read all these sites, there will be another 60 million sites. So he told me, just don't try this. You will never succeed in it. Keep in mind, only 20% of the people will remember 20% of what we said 20 minutes after your lecture. This is very true. You know, people forget what you said. I'm sure you don't remember who was the speaker last year for this convention. But, you know, things happen. You can't remember everything. So this is one of the summary slides that I have prepared, trying to look at the thyroid cancer as the good, bad, and ugly. We coined this terminology and everybody uses it now. American Thyroid Association also has adopted this. So the low risk is a young patient with small cancer. That patient is going to do very well. We always tell that patient will outlive the treating physicians. So I have a philosophy. Always take the youngest surgeon in the operating room, because you are supposed to outlive that guy, right? If he's supposed to live 75 years, you already got 75 years in your pocket. So that's the low-risk group, excellent outcome. The high-risk group is the worst. Older people, larger tumors, or the tumor which has high-grade histology, they don't do very well. And now we know, as I told you in the beginning, we need to find out who is not going to do well. This group, if we want to invest our time, our energy, our resources, this is the group. We keep arguing about this group because we love to argue with each other. But this is the group where we can show our advances, our analysis, good surgical skill, and multimodality treatment. And it is the intermediate risk group that we coined at Memorial, which is a young patient with bad cancer or old patient with good cancer. Keep in mind, if I have a thyroid cancer and it is small, below 2 centimeters, the possibility I will die of that cancer is much less than flying to India. So it is more likely you are likely to die natural death than from the thyroid cancer. So when you select the treatment, the low-risk group, you can take out one side of the thyroid. Remember, thyroid is like a butterfly. Take out one wing of the thyroid. The high-risk group, be very aggressive as you can. Do the best operation. You require other modalities to be involved. And it is the intermediate risk group where you use your discretion, what we call today, and this has become a buzzword in America, is a precision treatment. Everything is precision care. Precision care means adopting the best care to the benefit of the patient. And that is very, very important now. So the preoperatively, if you want to prepare this patient for surgery, do the preoperative workup. I still believe very strongly the clinical exam is very important. For all practical purposes, clinical exam has been forgotten in America. Nobody does a clinical exam. They're all into the investigations. They look at the chart the day before. Everything is written there, and nobody spends time in examining the patient. But the art of medicine is clinical evaluation. I strongly believe in that. And the hard and fixed nodule, irregular borders, very important. The ultrasound has become a cornerstone of evaluation. I think we would not do anything today for thyroid without ultrasound. And one other investigation which I like to do in advanced thyroid cancer is a CT scan. It gives me a better idea about the location of the tumor, the three-dimensional view of the tumor, and what I'm likely to contemplate in the operating room. So for me, the CT scan is very helpful. MR is another investigation, but I just don't know how to interpret it. I think for a surgeon, CT scan is exactly the anatomical evaluation, and I like that investigation. In the operating room, what do you do? The most important job for the surgeon is to make the best decision. And the best decision is this patient going to be benefited by lobectomy or does he need total thyroidectomy? Keep in mind, the role of radioactive iodine is going down and down today. It used to be a standard of care, total thyroidectomy, radioactive iodine. It was like a one-size-fits-all. But we have moved quite a bit from that now, and we rarely use radioactive iodine. We use it in a very selected group of patients, unless the patient has 20 positive nodes or the tumor is very large, where you feel the recurrence rate is extremely high. So this was one of the interesting paper I wrote, maybe about 30 years back. I looked at the low-risk thyroid cancer, whether you do a lobectomy or total thyroidectomy. Take a look here. The survival is the same, 99 to 100%. There is more, you are more likely to die in New York by hitting the taxi driver rather than thyroid cancer. Actually, we make a joke many times. The low-risk patient is more likely to get into trouble by coming to the hospital rather than staying at home. Stay at home, you will do very well. No doubt about that. So you can see here, the survival is the same, except what has not been added here is the outcome is much better. What we don't put in the equation is when you do a bigger operation, you get bigger complications, bigger problems. And all that you need in your career is one young woman with permanent hypoparathyroidism. Believe me, she will curse you for the rest of her life. The best thing is just marry her, so don't worry about it. So she won't complain about you, but that is the worst complication you can see. And there is always a debate about total thyroidectomy versus lobectomy, and this was one of the best statements you will read. And you can use this for any debatable subject. The fact that total thyroidectomy can be performed safely does not necessarily mean it is indicated in all patients with thyroid cancer. An operation not worth doing is not worth doing well. And I think this is a statement, you can use it for breast cancer, you can use it for pancreatic cancer, you can use it for rectal cancer, almost everywhere. But we use this for thyroid cancer as a favorite statement. There are many publications which come up. This is the SEER data publication by Mendelssohn. I had an opportunity to write editorial on this subject. And he came to the conclusion, after reviewing the data from SEER, which was like almost 50,000 patients with thyroid cancer, that the outcome is the same. In younger patients below the age of 45, I think they do remarkably well. if it comes to thyroid cancer. The age has changed now. From 45 now we have gone up to 55, and there is a lot of debate now whether we should go up to 60 as a low-risk thyroid cancer. And the more data we generate, I think this will happen probably in next few years. The ATA guidelines, which are like a gold mine of information, the 2015 guidelines are almost the same that we have been practicing at Memorial for a long time. It has not changed. That's why we don't pay much attention to these guidelines, because that's the same philosophy we have been practicing at Sloan Kettering. And again, you will see here, lobectomy is a choice of operation for majority of these patients. Again, you will see here that the previous guidelines, which were written in 2009, they supported the idea of doing total thyroidectomy and radioactive iodine for almost every patient with thyroid cancer. It changed somewhere in 2015, and now we rarely do total thyroidectomy on these patients. And this is the classical statement, less is more. There is only one cancer in the human body where less is more. This is also true in breast cancer, and I think there are many prospective studies in breast cancer. Unfortunately, there are no prospective randomized studies in thyroid cancer. It is just not possible to do those studies, because you will require a large number of patients to be followed for many, many years. And remember, there is a lifespan of every thyroid surgeon. So it will come to the end, but the study will go on, and nobody will carry that study. But when it comes to the understanding of less is more, I put it in right perspective. More is always better in life, right? I want more fame, I want more money, I want more house, etc. But in thyroid cancer, remember, less is more. What does that mean? For thyroid cancer, less is always better. And if you put it in perspective, the outcome or the quality of life, I think we'll get that better idea that less is better in thyroid cancer. If you look at the data, our own data for last 10 years, the long-term follow-up, whether you do a lobectomy or total thyroidectomy, the outcome is the same. So if the outcome is the same, why hurt the patient more? And even though people say, hey, it's no big deal, take one thyroid pill, ask the patient who is undergoing this treatment. They suffer a lot. Their quality of life is not the same. They don't have the same enthusiasm or energy as somebody who has done a lobectomy. And luckily, we are very fortunate at Memorial. Not only our surgeons have the unique understanding about thyroid cancer, but our endocrinologists agree with us almost 100%. I think the new endocrinologists who have joined, they have the same philosophy as we have at Sloan Kettering. If you look at the national data, this is the NCDB data, 61,000 patients, and they looked at it very critically. You will see the outcome is the same. The long-term outcome is the same whether you do a lobectomy or total thyroidectomy. And this is the classical statement that we use at Sloan Kettering: let the punishment fit the crime. If your punishment is small, if your crime is small, you don't need to send the patient or the individual to the jail. Just give him a little bit of a smack and he will understand. The same philosophy. I have a very strong philosophy that if the tumor is small, you don't need to be too radical. And I think we learned that in breast cancer long time back. Bernie Fisher made a name on that. He was nominated for Nobel Prize several times. He didn't make it, but the message was very clear. But I don't think we have used that message in many other human cancers. So one of the classical story goes along. You've done a lobectomy, the frozen section is benign, the final report comes after 2 days or 3 days, it is malignant. What do we do? Even in the United States, it used to be a knee-jerk reflex to bring the patient back to the operating room, do a completion thyroidectomy, and give radioactive iodine. I think we have moved a long way from that philosophy. And as I mentioned, this was a knee-jerk reflex. We don't do that anymore. We didn't do that all along, and we don't do that anymore. This was another paper I wrote back in 1990, exactly 35 years back, and I developed the decision-making in thyroid surgery. And the decision-making about the whole debate was extent of thyroidectomy, and you use all the parameters that are available. The ultrasound, the risk factors, the prognostic factors, and we came up at Memorial with the prognostic factors. We were probably one of the earliest group trying to analyze the patients in thyroid cancer into low risk, intermediate risk, and high risk. I think that was a major contribution from Sloan Kettering to the risk analysis. Other people did it, but they did not develop an intermediate risk group. They had the low risk, which was 80% of the patients, and high risk, which was 20%. We changed that quite a bit. Good judgment comes from experience, but in life, experience comes from bad judgment. And believe me, we all have made bad judgments at one or the other time. You know why the surgeons are the most humble medical fraternity? Because something hurts them all the time. I didn't do something in my life I should have done for that patient. And that will be with you for the rest of your life. Wish I had treated that young girl in a different way. She would have seen the day of light today. But something happened. And again, we don't do it purposely. It's a science that we follow through. But again, the surgeons remember that for the rest of their life. What has changed when it comes to understanding of the completion thyroidectomy? I think we have better understanding of the biology of the disease. The outcome is the same. I won't go in the details of this, but all the retrospective data or the retrospective studies from MSKCC, CR data, NCDB, they have shown the outcome is the same. And again, these data are very important. We use them all the time. They teach us a lot. But again, you have to take it with a pinch of salt. What happens when the final pathology report comes? That's the major issue. And this is where we reanalyze the data more critically. The papillary thyroid cancer is not one entity anymore. There are many variations in that. The tall cell is very important to understand. Virginia Livolsi from UPenn, she popularized the tall cell. If there are more than 50% of the cells showing tall cell, that is more aggressive cancer. Hobnail, diffuse sclerosing, insular, poorly differentiated. This is where you need a good pathologist. We can't work alone. Every cancer treatment is a multimodality now. You need to reach out to a radiologist, you need to reach out to the pathologist, the cytologist, endocrinologist, and I add one more, your own colleagues. Don't be shy to pick up the phone and ask your colleague, what would you have done or what would you do? What is your advice to me? It doesn't matter how old you are. You always need a mentor in surgery. You can't do the best patient care without having a mentor. And mentor should be one whom you can rely on, is competent, and you feel very comfortable asking questions. And we all have that. Preoperative aggressive pathology is very important. Nowadays, everything is molecular analysis, whether it is pancreatic cancer, brain tumor, and for thyroid cancer, BRAF and TERT is very important. Those are generally considered to be more aggressive cancers. But remember, you don't get BRAF and TERT in a low-risk thyroid cancer, small thyroid cancer. Generally, those are big, those are fixed tumors, so you know in advance that this is going to be more aggressive thyroid cancer. As I mentioned before, quality of life is very, very critical. We pay attention to that more now. Remember, no matter who does the surgery, there is 2 to 3% complication rate. Whether it is postoperative hematoma, nerve injury, parathyroid problem, or the patient's inability to adjust to the thyroid medication. I use the analogy of the diabetes. Diabetic patient lives a normal life, nothing changes, but the quality of life changes. And the diabetic patient cannot eat a cake on his own birthday because his wife will tell your glucose is going to go up, stop eating cake. The same analogy we use when it comes to thyroid cancer. Do not use one size fits all, use personalized precision treatment, and this is very, very appropriate for decision making. There are several recent publications, especially from Quan Du and Janice Pasica. They analyzed their data and came up with the conclusion that 50% of these patients would require completion thyroidectomy. That was not correct, because they were not identifying the intermediate risk group critically. They were just taking every intermediate risk group and saying these patients require bigger operation. And that was not true. We don't agree with that, and I think we have a polite difference of opinion here. This is one of the nicest paper you will read. It was written by one of my colleagues, Laura Bukai. What she did was very interesting. She looked at the intermediate risk group patients where the debate generates, the controversy comes up, and she divided that into the low intermediate risk group and high intermediate risk group. Somebody with 20 positive node is a high intermediate risk group, because that patient is going to likely to recur. If you have taken out 20 nodes, there is a 21st node hiding somewhere. And it's the time that will show you that this patient will recur. Most of those, we don't use radioactive iodine. I think we are using it very selectively now, unless patient has pulmonary metastasis, or we are concerned that this patient is going to recur in next few years. Understanding between the patient, surgeon, and the endocrinologist. This is what I call isosceles triangle. You have to have a good understanding between the patient, the surgeon, endocrinologist, and I always add, the patients get opinion. You know who gives the patient opinion that Dr. Shaha is not right? His gardener and the mailman. He says, oh no, you have cancer. You got to get your whole thyroid out. Don't listen to Dr. Shaha. He's in an academic institution. That's not true. We do understand the biology of thyroid cancer, and that this is very important. The need for future studies, I think, is very important. Unfortunately, this is not going to happen, prospective randomized studies. So we have to go with what we believe in and what is the best quality of life for the patient. Keep in mind, the complications of thyroid surgery are directly proportional to the extent of surgery and inversely proportional to the surgeon experience. I think this is every thyroid surgeon will know. The surgeon experience does count. There are many papers published in the United States about surgeon experience. It was very common for the cardiac surgery. Now it is for thyroid surgery also. Who are the patients who are more likely to require completion thyroidectomy? The larger tumors. As I mentioned to you, the high-risk tumors. If there is a gross extrathyroidal extension, if there are multiple positive nodes, if the nodes are big, more than 3 centimeters. I think we learned that from the Japanese group. That was the worst prognostic feature. And they put them in the category of aggressive thyroid cancers. If there is a minor extrathyroidal extension, and I think the new guidelines have come, the new staging has changed quite a bit. The minor extrathyroidal extension, the outcome is the same. There is hardly any meaning to that. We don't put that in the equation, and we don't upstage those patients. Keep in mind, still, about 60 to 70% of thyroid cancer patients are low risk, stage 1 thyroid cancer. What is the best time if you really want to do completion thyroidectomy? Either do it in the first week where the planes are clean, or wait 3 months. Let the scarring go away, and then you operate on them. You go in 1 month or something, it is like a mush. It is Swiss cheese. You can't find anything. The complication rate is much higher. I already talked to you about this before, the variety of different categories of thyroid cancer, but one subject which has generated a lot of debate is the angio invasion. If there is a major vascular invasion, and we have used the cutoff of 4 foci of vascular invasion. This was just the analysis of the data. The Japanese feel 2 foci is not good. We feel 3 foci is okay, 4 is not good, and we would consider a completion thyroidectomy and giving radioactive iodine because there is a higher risk these people will develop distant metastasis. What is the surgical principle when it comes to thyroid cancer? Evaluate the risk group, the prognostic factors. The most important anywhere in oncology, cost effectiveness. Make sure that you are cost effectively taking care of the patient. Avoid over treatment and treatment related complications. I told you about hypoparathyroidism, nerve injury. Those are the worst complications. And the idea of management of thyroid cancer, don't overdiagnose, don't overtreat. And we learned this from the Korean group. I think they taught us quite a bit about it. And they are now stopped doing the routine ultrasounds of the neck. The routine ultrasound in Korea was very popular. They will have a mobile van, they will stand near the subway station, you go in, get an ultrasound, they will tell you you have thyroid cancer. Did we help the patient? They were living very happily. Now we diagnose something that we should not have diagnosed, and we are now hurting the patients and the families. This is the kind of flow chart we use when it comes to management of the thyroid cancer. We look at the patient characteristics, the medical team characteristics, and the tumor characteristics. Again, you can copy this slide for any human cancer. These are the three characteristics: the tumor characteristics, patient, and the medical team. And then you make the use the intraoperative findings and the postoperative pathology report, and then we come up with this: what is an ideal patient, what is inappropriate and appropriate. And the inappropriate patient is the one where we would be more aggressive, because we know this patient is not likely to do well in the long run. I hope I not confuse you, but I just want to leave a message. The good physician treats the disease, but the great physician treats the patient who has the disease. And if you want to be recognized as a good surgeon, use Dr. Pradhan's role model. Because it's not just being a good physician, you want to be a great physician, taking care of the patients the best you can. When it comes to thyroid cancer, there is a minimalistic approach and the maximalistic approach. And we need to realize that the minimalistic approach gives the same outcome. As a matter of fact, in Japan, majority of the thyroid cancers below 1 centimeter are not operated, they are not treated. They just tell them, this is normal, you are expected to have this, just live normal life, we'll see you next year, we'll get another ultrasound. If there's no change, we'll continue to monitor you. Very difficult for patient emotionally to accept that I have cancer, but this doctor doesn't want to operate on me, but you have to explain them the biology of thyroid cancer. Keep in mind the decision-making in thyroid surgery is not only surgeon, the endocrinologist. What does the internet tells you, the Google? The patients come prepared. Now, the things have changed in last about 8-9 months in the United States, because by law now, the patients get the notification of their pathology report, of their blood reports. They get it before I get it, because their computer is on 24 hours. And they get the intimation from the hospital, your pathology report is ready. They read it. Within 2 minutes, I get a call from the operator. This patient is very anxious, wants to know what to do next. And it's very difficult. I have to call the patient at 11 o'clock at night because she cannot sleep. And I know if she cannot sleep, I cannot sleep. So the best thing is to make a call and tell, don't worry, everything is fine. I'll talk to you tomorrow. It doesn't work that way. I hope I have not confused you, but remember, the most important thing in medicine is to leave the audience confused. If you make it very clear, you will never get invitation again, right? And the idea is to make sure you get invitation again by leaving the audience confused. So I'm going to make it very simple. The tumor characteristics, the patient characteristics, and medical team characteristics. And those are very important. Preoperative classification, the intraoperative findings, and divide the patient who is the ideal, appropriate, and inappropriate. And I think this is very, very important when it comes to management of thyroid cancer. What are my indications for completion thyroidectomy? I have developed some philosophies. When the pathological features are really adverse, means gross extracellular extension. But remember, as a surgeon, you know it at the time of surgery, so you don't need the pathologist to tell you. But if there is a major vascular invasion, that's where the debate comes, because you cannot appreciate that on clinical judgment. You need a pathologist to tell you there is a major vascular invasion. Keep in mind, total thyroidectomy is one-way traffic. You can't come back on that. You cannot turn back. Lobectomy is a two-way traffic. You can always make a U-turn. You can always take it out. You can't put it back in. When we tell this to the patient, they understand that very well. You can always take it out, but you cannot put it back. This is our philosophy. There is an evolution of surgeon. I think many of you probably have seen this slide. There are 3 stages in the life of a surgeon. The first stage is how to operate. You finish your fellowship, you want to be aggressive, you know how to operate. The next stage is when to operate. That is very critical. You make a decision when I want to do the right operation. And the last stage is when you have gray hair, or many of us with no hair, they know when not to operate. And there is a 4th stage, which I cannot write it on the top, is when to send the patient to somebody else. You know this patient is not going to do well. You know, I call this physician's bill of rights. I should have the right to tell, no, I don't want to take care of you. You are a pain in the neck. I can't handle you anymore. You know, I can handle my wife, but I can't handle you. So take care of those patients. Keep in mind, commonplace clinical problems in medicine are approached in a diametrically opposite ways by surgeons with similar training background. We read the same literature, right? But we argue about everything based on unique personal experience, vision, and the most important thing in surgery is surgical prejudice. I changed that word from prejudice to surgical ego. We all have ego, right? I would not have become a surgeon if I did not have ego. I would have become a psychiatrist, right? Very easy. Don't have to worry about it. Do whatever you say is right, correct? All that you have to do is spend 1 hour, get your bill, and that's it. Don't worry about it. But it doesn't happen in thyroid cancer. This is our multidisciplinary group. I think every institution now has, in England, that was very popular way before we started in the United States. This is our multidisciplinary group, and you can see most of the people who you are quite familiar with. I'm just going to leave a message for the residents in training. There are a lot of fellows here. I know this conference is supposed to be for them. Work hard, no doubt about that. Be honest. Be humble. Have a great attitude. Enjoy work and family. You know, unfortunately, I have to be very honest. As a surgeon, we don't pay much attention to our family. And I think that is something that hurts us all the time. And as our children grow, and we have grandchildren, and we know how much they give the love to the grandchild, you feel, did I do the same thing in my life? Or I was more married to the hospital, I was more married to the work that I enjoy most. But luckily, our children understand that. They know that my dad is taking care of the cancer patients, and they're quite happy about it. When you go to the hospital every day, you have to enjoy it. Working in a cancer hospital is not easy. You need to have passion. You need to have a determination that I'm going there, I'm going to work hard to take best care of the patients. I'm going to show you 2 aphorisms because they are important. During the difficult part of the operation, step out of the operating room to make an emergency phone call or talk to the chairman. This is what we do in the operating room all the time, right? Whenever there is a difficulty, you come out of the operating room, Dr. Pradhan, what would you do? And then you write a note on the chart, right? I consulted with Dr. Pradhan, he said do this, so you're quite happy about it. When you don't know what to do in the operating room, use irrigation. right? We do that all the time. When you don't know what to do in the ICU, use steroids. Steroids and surgeons, they go hand in hand. You get a call at 3 o'clock in the morning, some respiratory problem, and the answer is very simple. Give steroids, I'll see them in the morning. At 8 o'clock, the call has changed. Now I'm sorry, I can't take care of the patient. Call somebody else. This is a very classical story. So I'm going to conclude in next 1 minute. I know I've been saying this for the last 15 minutes, but I just want to show you a small truth to make life 100%. We all want that 100% life, right? And I don't know what it is. I have not been able to figure it out. But take a look now. And I'm going to put you to work a little bit. You have to do some arithmetic, very simple, but let me just show you. Just go from A to Z or Z. Each number, each alphabet has a number, 1 to 26, correct? So keep that in mind. So what am I going to do? I need my life 100%. Hard work, right? If you count the word, alphabets, and the numbers, it comes to 98%. I'm looking for that golden number, 100%. What is it going to be? Let's take a look. Knowledge, 96%, not very good still. 100 papers, 600 papers in PubMed, doesn't help. Okay, let's see now. Love, 54%, no good, doesn't help. Luck, yes, we always talk like that, right? I wish I was born in the royal family, right? I would have been against all the circles of life, but still it comes to 47%. Let's see now. Then what makes 100%? We're looking for that golden number in our life that will make 100%. Is it money? No, 72%. Is it leadership? President of this, leader of this? No, 89%. So every problem has a solution. I'm trying to make it 100%. You want to go to that 100%, and ladies and gentlemen, it's the attitude. You put the words attitude, and it comes to 100%. And that's what is important in surgery, that is also important in life. Change your attitude, and everything in life will change. Thank you very much. You can close the slides.
Thank you so much, sir, for such a wonderful talk. Now we call on the dais Dr. Roshan Chenoy, our Head of Histopathology Department at HNCII, to read out the citation and felicitate Dr. Ashok Shaha as a mark of respect.
The citation was to be read out by Meher. She is the queen of HNCII. Ashok, I, and Meher have been friends for many, many years. And I thought it was appropriate for Meher to read it out, but unfortunately she's unwell today and unable to come.
All the dignitaries in the audience, ladies and gentlemen, this is the citation for Dr. Shaha. The trustees of the CanCare Trust and the medical staff of this hospital take immense pride in presenting the citation of distinguished friend and mentor of HNCII to Professor Ashok R. Shaha. We present this in recognition of your unparalleled contribution to the field of head and neck surgery and your extraordinary legacy as a global leader and educator. With an academic career marked by over 825 scientific publications, including more than 700 peer-reviewed papers, your work has illuminated the pathway for generations of surgeons and clinicians worldwide. As attending surgeon at the Memorial Sloan Kettering Cancer Institute, Alan H. Selig Chair in head and neck surgery and professor of surgery at Cornell, your leadership has extended to holding the highest offices in national and international surgical societies. Your visionary guidance as president and chair of major scientific bodies and as educator and mentor has inspired excellence, collaboration, and compassion across continents. A humble, ever-friendly person to the Indian community, you are known not only for your technical brilliance, but also for your warmth, integrity, and tireless service to patients and colleagues. You are an extraordinary individual, a true legendary visionary in the field of surgical oncology, a son of India. On 23rd August 2025, the occasion of our second anniversary of HNCII, we are honored with gratitude and admiration to present this citation to you, Professor Ashok Shaha, in recognition of your lifetime of service, scholarship, and mentorship. Thank you.
Now we invite Mr. Yesdi Maligam to please present the memento to Dr. Ashok Shah. Thank you, sir. Now I request Dr. Pradhan to introduce our next chief guest speaker, Dr. Farokh Udwadia.
To introduce Dr. Professor Farokh Udwadia would be an insult. If you those who do not know Farokh Udwadia and what Farokh Udwadia has achieved in life will just fail in their general knowledge. Just fail. But I will only tell you one thing, since I've had the privilege of being in the profession for more number of years than most of you present here, is that people build institutions by making a new building and bringing in all the services. But here is Dr. Udwadia, who changed a maternity home, nursing home, into a major institution that the entire country looks up to, the Breach Candy Hospital, by adding the intensive care unit. If I'm not mistaken, I think that the intensive care in India has started with Dr. Farokh Udwadia. I think it was KEM Hospital, Bombay Hospital, and Breach Candy Hospital. I do not remember which of these was three, but the classiest has been the Breach Candy Hospital. And it is amazing how In most ICUs, you will find that if a patient is there for about 8, 9, 10 days, then the complications start, and then you just go downhill. Here you see patients for 8, 10 weeks, and they are just sustained with that stellar discipline that is inculcated into every worker in the ICU. So you don't get those complications of tracheal stenosis, you don't get those complications of resistant bugs for a long, long, long time. And I think that it is amazing how one person's dedication and discipline has brought about such an institution in the city and in the country. All the rest has followed later on. That is the only introduction I can give from what I have seen evolve over the years. You've seen some of the topmost leaders in the country taking treatment there. But what has started is that ICU, that critical care. That is all the information I can give. Not about the Padma Bhushan and about this professor and that professor awards. So, sir, thank you very much for coming. Thank you very much for being our guest speaker and breaking the monotony on thyroid cancer here. Thank you, sir.
Well, friends and colleagues, I know this is a very serious conference on very serious matters. So you can please sit back and relax, because I'm not going to tell you anything which is very serious. So you can sit back. Well, critical care was absent when I was trained at the KEM, became honorary at the Breach Candy, and I've retired as an emeritus professor of medicine there. So when I joined the Breach Candy, it was a nursing home, and I realized that it was very difficult to attend to patients who were seriously ill because the staff was limited, the nursing was limited. So I decided to set aside one room in the Breach Candy Hospital where I could look after patients better than what I could otherwise do. In that room, we had a surgical bed. We had a monitor which could just look at the ECG. We had a Beaver's ventilator. I don't know how many of you have heard of the Beaver's ventilator. It is obsolete now. Anyway, we had a Beaver's ventilator. We had an endotracheal tube for intubation, etc. And we had emergency medical supplies. And the doctor, the resident who used to look after the ward, was told to make sure that he looked after that particular room, which had usually more ill people than otherwise. That's how we started. Now we had successes and failures. There was an excellent nurse, full-time, daytime, all through, and nighttime too. And we had a nighttime houseman also who was told that he had not to leave the ward and be there. And there was a hotline from that room to my house, so that anything anyone wanted, I would be there to advise or even come over and see the patient. This is how it all started. And we had people we perhaps saved, and people even then perhaps we lost in spite of what we did. And I realized that it was not a first-class affair at all, but even so it was better than nothing. I'd like to sometimes go back on some of the patients, not who lived here, but the patient where I learned a lot. There was a lady from Air India whose husband was high up in Air India, and she came to the wards actually with vague abdominal pain. And I went to the JJ, and when I returned back, she said, my pain has suddenly increased. She had, in short, an intestinal obstruction, and my surgical colleague operated upon her. It was a very tight obstruction, and the amazing thing was she hadn't complained of severe pain before. Anyway, he did an end-to-end anastomosis, and she was all right for 24. I put her in this room that we had. She was all right for 24 or 48 hours. And then she started becoming breathless. And she was not old, she was in her early 40s. And I thought, I wonder why she's breathless. And there were crackles at the base. I looked at the intake-output charts. They were fine. She was not volume loaded, etc. Is it a heart? The ECG was normal. There's no history of heart problems before. Nothing in the family also. I was intrigued. And we gave her a diuretic. I could see that there were shadows in the lower lobes. These increased within a matter of 2 days to literally flood her lungs. We had her intubated. I had her ventilated. I struggled as hard as I could. She died. I put her death down as left ventricular failure because I didn't know it better. I didn't realize that within a short while, a paper came from America by Ashberg and Petty, who for the first time described the adult respiratory distress syndrome, or they called it at that time the acute adult respiratory distress, and realized then that in all probability, what had happened post-op was a complication which was the adult respiratory distress syndrome. This was a learning lesson. We had some patients like that later on, within that room also. A few were salvaged and a few were lost because the adult respiratory distress syndrome, one of the most important things you need to do was to put PEEP, positive end expiratory pressure. And the poor beaver's machine had no way in which you can put beep. But necessity is the mother of invention. So what we did was we took the expiratory tube and dipped it 8 centimeters under a bottle of water. So that was a positive end expiratory pressure that we managed to apply. Now, a tremendous event came which changed my way of thinking and my life also. I must dramatize this if I may. It was a Sunday, 5 o'clock in the evening. I was going to take my wife and children to a picture, which we rarely did. It was at the Regal that we were wanting to go when a phone call comes, sir, there is a patient admitted. She's an American lady married to an Indian man, Indian husband, and she says that she can't breathe well, but I've examined her thoroughly. She's functional. There's nothing wrong with her. See her tomorrow morning. I don't know what prompted me, maybe because we were dressed and we were early. I said, I'll just go up and see what's the matter. I'm sure I'll come down in 5 minutes. I went up. I saw this lady and I talked to her and she said, I have difficulty in breathing. I said, what's the difficulty? I said, I can't describe it, but I find I'm not breathing as I normally would. I realized that she was not functional. When you talk to a patient, properly, and for a length of time and ask her about this or that or the other, or talk a few things, I realized that this lady was very, very, very sort of down to earth. She was managing a household on her own. You know how some of these white people are. They want to do everything by themselves. She looked after the house. She looked after the husband. She was quite perfect, I thought. But I couldn't quite fathom. I examined her like a tooth comb, with a tooth comb. All her symptoms were, the lungs were perfect. The respiratory system, alimentary system, cardiovascular, particularly the nervous system, I went over thoroughly. Not a thing could I find. Jerks were normal, planters reflexes, sensations normal, power, tone, everything normal. I just couldn't understand. But I realized that something was wrong because she was not functional. I asked her to take a count, and she counted up to 30, which was not bad, I said, but I waited. After a time, I said, count now again. This is after about half an hour waiting with her. She could only count up to 20. I realized that there was something wrong with her respiratory muscles. But I said, what could be? All her other muscles are all right. All her reflexes are all right. But I had the wisdom, which was intuitive probably, to say, please call the resident anesthetist and ask him to be ready, if needs be, to intubate. This was not in the separate room. This was in the ward. So we waited for some time, and then the anesthetist came, etc. Then, to my horror, before I could know what was happening, she stopped breathing. There was a panic. So I told her, for God's sake, intubate. I gave the oxygen, but intubate. But the wretched bed had those bars, at the head. So I said, I can't intubate, sir. How can I intubate? I can't see. I can't see the larynx. I can't put my head in. I can, damn you, intubate. I don't care. He tried and tried. At second, when he would come back out of it, I would just give him the oxygen, put in the oxygen, use the ambu bag to give it, but I couldn't do that. Come on, intubate. Ultimately, I don't know what he did. I think I pushed the tube in. I don't know where it is. Please auscultate. I auscultated, and thank God, I said, oh, it's in the trachea properly. So then we put her on the machine. Now we had graduated from the beavers to the birds ventilator. So we put her on the bird ventilator, and she was all right. She was breathing all right, pulse all right, blood pressure. It was about 2 hours later that I went home in a taxi. I had to send the children home already, saying, you better go, we won't be able to go. Next day, I get up. I quickly finish the Parsi general round because there were some ill people there, and I go to breech candy. And I was shocked. This lady was completely paralyzed. She couldn't move a finger. She couldn't move a toe. She was totally paralyzed, completely paralyzed. And I had examined her at 7 o'clock, 6 o'clock, 7 o'clock in the evening, and she was perfectly all right as far as her power was concerned. Cut the long story short, she had acute poliomyelitis, which had not only involved the spinal cord, but which had also involved the bulb, so that she had no way of, there was an endotracheal tube, she couldn't speak. But I was sure, that she had marked fluctuations in her blood pressure. She was extraordinarily ill. I thought we were going to lose her because of the bulbar involvement in poliomyelitis. With great difficulty, I persuaded the authorities to give me a larger room. So somewhere on the first floor, I still can't recollect where on the first floor. This is on the second floor, third floor. Somewhere on the first floor, they gave me a large room, which I think was to be incorporated into the ward later on. And there we struggled with her. At last, after 6 or 7 days, things seemed to be settling down, and she was on the birds machine. There was a friend of this husband who was in Pune, who was an anesthetist, who came over and helped me to help manage this patient. Now, a call comes. I am so-and-so speaking. I am the brother of the patient you are treating. I want to know how she is. So I told him, by the way, I am a cardiac surgeon at the Los Angeles so-and-so hospital, cardiac hospital or whatever it is. So I told the person, this is so, this is that. So he asked me, and what are her blood gases, doctor? I said, I can't tell you because we don't have a blood gas machine here. I'm just managing like that. How can you manage a patient without a blood gas machine? I said, so far I've been successful and I hope I continue to be so. So I'm coming with a blood gas machine right now. So he came with the first possible, he was the brother. He came he was out on a trek and couldn't be contacted. And this is what happened when he was contacted. So he came over with a blood gas machine. So we took the blood gas machine, carried it like a baby into the laboratory. And then he said, the technician said, I don't know this machine. I can't set this machine up. So I asked him, can you set it up? The man said, no, I am a surgeon. I can't set up a machine. So what shall we do? So he said, oh God, I'm going back. I shall learn how to set up the machine and come back. So he did that. That was the first blood gas machine in this country. After a little bit of teething troubles, we got to know the blood gas. And so, now I forgot to tell you, in the physical examination, everything was normal, but I could feel a lump in the lower abdomen, and I asked her, there's a lump in the lower abdomen, have you conceived? Yes, he said, I am 3 months pregnant. Now, during that madness that we had on that evening, the lady had been repeatedly hypoxic, repeatedly cyanosed, deeply cyanosed, with a 3-month baby inside her. So we went on looking up. She was totally paralyzed, remained totally paralyzed. For 6 more months, we kept her on the breathing machine, and she delivered on that breathing machine. I told her before, look, Melody, there's a great risk. You have been deprived of oxygen for such a long time, I would, if I were you, I would remove this baby. She might be. He said, no, I will not do that. Whatever happens, I will keep this baby. You won't believe it, when the baby was born, perfectly healthy and remained perfectly healthy. Now, how can you explain that? I don't know, because the lady was really hypoxic for quite a long time. So that was good news anyway. So this is how ultimately she delivered. The brother took her to Los Angeles, where there was a superb physiotherapy center. There was some improvement in something. She could sit on a wheelchair. She wouldn't fall over at least. She had, of course, a tracheostomy. I had a tracheostomy done on that very same day when all this happened. And ultimately, she came back to her place in India because the husband had his work in India. And then a funny thing they explained, which I've never been able to understand. Sometimes she would be able to breathe, and most of the time she would be on the machine. The husband knew how to handle the breathing machine, ventilator perfectly well. And she was told to breathe like a frog. What is frog breathing? They said, what is frog breathing? You take a bolus of air in the mouth and learn not to let it go into the esophagus, but push it into the trachea. I tried for a week to do that myself. I never succeeded. Anyway, this is the story of this lady, and from that time onwards, my mission started. I told the Breach Candy Hospital that we need to do something about this. And they were really, they were all expatriates, but they were all wise people, heads of big corporates in Bombay, companies in Bombay. And he said, all right. So we had a 2-bedded unit on the first floor, where there was a doctor, specially there, only for the 2 beds, mind you, and nurses, and much better equipment. I remember there one patient, and these memories come back to me. This was a young woman of about 19 years old who came with eclampsia. And she was frothing and convulsing almost all through. And over a period of time, she developed multiple organ failure, every single, deeply comatose. Of course, immediately we had the baby removed, you follow, but otherwise she was very, very bad. One of the worst patients as far as critical illnesses go. She would have got the SOFA score, maximum score in every moving system, every running body system. We managed to salvage her. It was one of the most gratifying things as far as I can remember. And I still remember that lady, and she's still well, and she's very, very good indeed. And then there was a very funny incident there. Dr. Hiranandani was a head and neck surgeon in those days, and there was a person with some malignancy somewhere or the other, and he had chopped off everything that was to see. There was nothing that I could see as a physician, you follow. And one day, this is a patient from the Middle East, and one day there was a frantic buzz from all the wards, come, emergency, emergency. And apparently some vessel had broken open, and there was a spout which went to the ceiling, and somebody was putting all pressure, but nobody would catch what was bleeding, what to do. How can you go on pressing things? One lazy houseman who was last woken up comes around the corner in the bed. What's the matter? He tells me. I said, he's bleeding, and they can't see, the surgeon can't seem to catch what to do. He's just bleeding. Where is he bleeding? I said, from the neck, can't you see? So he said, come, where is the artery forceps? Give me the artery forceps. He just goes up to the bed, looks up at the ceiling and closes it like that. And the bleeding stopped. Miraculous. I said, what have you done? What did he do? He doesn't say a word. He just walks out and goes back to bed. So these are things which you can't forget, you see. Now, I told the people that we need a proper good ICU. And that is when the first 8-bedded ICU that we have in Breach Candy came up. Beautifully designed. None of the current units are well designed. The sister at the desk could see, out of the 6 beds, she could see 5 beautifully, 6 beautifully. 7th was in one corner. She had just to swivel a little like that. And the 8th was behind her. She could swivel. That was the only one where she had to swivel and look at it. They were all glass, so you could see all through them. So we had that. You won't believe it. There was just one doctor. He was my second in command. He was Dr. Sunawala. And he had been given a bedroom upstairs. And the moment he was called, he would come down in 2 minutes at night. In the day, of course, he was there all the time. The nurses were excellent. We trained them beautifully. They would do anything and everything except intubate. They could recognize all arrhythmias. They could shock the patient. They could do everything except a central line and intubation. Those two they wouldn't do. She managed that extremely well. There were one or two things I laid down, I well remember. First, I said, you will treat all patients equally well. As we got to be very well known, there were many VIPs. I said, VIP or no VIP, you will treat the patient from the Godrej wing exactly as you're going to treat the VIP. Please remember that. The second thing I told the nurses, and this was very important, you know, when I used to see what was going around in the rest, there was a tremendous amount of nosocomial infections which killed the patients. So I made a decision that the urine, stools, and cleaning the patient should be with the nurse and not with the poor, the so-called great forced servants. The nurse had to do that because these people who are really illiterate and not knowledgeable would touch things here, touch things there, touch the tube coming here, and touch the bed soles, etc. And that was responsible for a great deal of nosocomial infection. And therefore, the number of nosocomial infections came down very, very, very sharply with us. There's some interesting things here also, which we learned, which I had a lot of pressure to withstand, you know. Because when the unit became very well known, people from Delhi, ministers, this and that, etc., would come here. But the rule was that you will treat everyone equally well. Now, I remember, for example, a young, not young, middle-aged pediatrician, consultant pediatrician, who was a consultant to my grandchildren, mind you, coming day and one day extremely ill, and I couldn't fathom what it was, and I still don't know ultimately what it was. I went on a Sunday morning, and I suddenly find person in red robes, or rather pink robes with water, flowers, etc. I said, what is he? Who is he? What is he doing here? So the sister says, he didn't listen to me, just walked into the room. I said, what are you doing? So he says, I am throwing petals. I've got Ganga water. I'm going to give her the last rites. I said, how dare you do this? She's alive. What damn you? I don't want you to come here. Get out of here. Amazingly, her husband, who was a surgeon and a dear friend, had asked the priest to come. I filled the whole thing out. I was under great stress because of what I did. But fortunately, miraculously, this lady lived. I don't know how, but she lived. They celebrated. I wasn't there at the celebration, but all of them, because she had a last circle of friends, doctors, etc. There was another patient then. This lady had a cancer of the pancreas, and being very wealthy, very rich and well-connected, had gone to America and they had removed the pancreas, etc. And she was there for many months and the cancer spread. So they removed this, removed that. I don't think they left anything inside the tummy. They removed almost anything that was to be removed. And then they sent her back saying to us that, now she's well. I said, what? She's well? She had 2 fistulas coming out of here. She was almost moribund. And you're saying she's well? They said, no, you just now manage her. She'll be all right. Obviously, she was not going to be all right. One fine day, at 9 o'clock in the evening, there was a knock on my consulting room door in the Breach Candy Hall. I used to work quite late then. And this fellow comes in, is a scruffy-looking fellow, and he sits down. How is my mother? I said, she's very bad. I told you. I told your dad also, she's not going to live. It's impossible. We can't do anything. We're just keeping her comfortable. She has to live. I said, I told you, we can't do that. It's not possible. If you don't make her live, and she fiddled around with her pocket and put a revolver on the desk. You'll see what happens to you. I said, really? What is this? It's a revolver. Is it loaded? I said, yes. He said, loaded, completely loaded. Then I said, have you heard of Mr. Colt? That staggered him. He stopped shooting me probably, stagger. No, who is Colt? I said, you got a revolver and you don't know who is Colt? Just who is Colt? Colt was the first man to design this revolver. Did you know that? And you know how he designed? I went on talking. You know how he designed it? He used to hold road shows. Until one day the road shows turned out rather badly. He stopped doing road shows to sort of design this Colt and sell it. For a second. Okay, I'm going just now, but if she doesn't get well, I might shoot you. It doesn't matter. But remember one thing, you will ruin the reputation of your good family. And my children won't let you go. They'll hang you sometime or the other for that. He just turned around and walked away. So that was another incident. And then there was another man, this was also interesting, he was very, very ill, a very famous man, but all were equal, and I all taught them, each one is to be treated equally. And he was so famous that they said, we will bring people from London and all that. I said, well, if you bring, you're welcome. So a young man was a superb endoscopist. And another young man who was a physician, and one, fortunately, an elderly surgeon in his perhaps late 50s or early 60s. So they came. This poor man was septic. He had severe sepsis, he had a fistula, and he was having bleeding from his upper GI tract. Our poor endoscopist here had done his best because it was sepsis, and you have erosive ulcers in sepsis, and they don't usually close quite easily. So this man comes in, he was well known. I know he was a very well known endoscopist. He does endoscopy and he tries to stop the bleeding stops, everything stops. And then he says, now he's all right, he won't bleed now. But he didn't realize that you have sepsis. Unless the sepsis is all right, he's likely to bleed. And he did. The next day he bled. So this young man walks in, strutting and said, and his face drops because I had been there earlier. I said, he's bleeding. He's bleeding. Oh, he's bleeding. Let's do it again. All right. They wanted to take him away to their place by helicopter or by whatever, air ambulance or whatever it was. But there was this rather wise surgeon. And he took them aside, talked to them and came back and said, no, doctor, we are not taking him. You've looked after him very well here, and it would be wrong for us to take him. So let him be here. He recovered. This man recovered too. So these are incidents that I well remember. Now comes another important phase in my life. One fine day, a colleague of mine died suddenly of a heart attack at the JJ hospital. He was a GI man, and he was looking after the tetanus ward. And his assistant came running to me, look, I can't possibly look after this ward. I don't know anything about it, and I'm not going to do it. Will you please help me and take it over? He was a friend and a colleague. So I said, let me see. I had, of course, looked after tetanus ward in my KEM days when I was a registrar. At that time, it was under J.C. Patel. And the only thing that we could do was give paraldehyde all the time. That was the only medication for. So I went to the tetanus ward. I was shocked. It was like a charnel house. 2 corpses already wrapped up in white, ready to go to the morgue. People convulsing continuously all the time. I said, this is terrible. I said, I can't manage this. How the hell am I supposed to manage this? How can I do this? Please. So I said, all right. Tell me the 2 people who are likely to die tomorrow. The mortality of severe tetanus was 100%. Absolutely 100%. So these 2 will definitely die tomorrow. So I said, I'm going to take them to the Breach Candy Hospital in my unit. If they live, I shall try and see if I can do something. After a great struggle, these 2 people, they were poor beggars from the streets, etc. They lived. So I said, then I'll try and see if I can do something. So I took it over. Now, how was I to manage this ward? There were no ventilators. No ventilators. Can you imagine? No ventilators at all. It was a dingy ward. Light had to be cut off because they would otherwise convulse if light fell on them. So I was staggered. So I had a brilliant idea. I was earning reasonably well, comfortable. I used to supplement my income by going to Hex Pharmaceuticals one day in the week where I was told to reply to letters that came to them. And I used to write the most uproarious, funny letters to the doctors who wrote them. They've still kept them, they said, those letters, as monuments for all matter. So there was a German gentleman called Mr. Winternitz who was in charge of the whole thing. And we'd become quite friendly. So I one day went to him and said, Mr. Winternitz, I want you to do me a favor. You are doing so well. You must donate something to this tetanus ward of mine. We want ventilators. In typical German fashion, he says, yeah, all right, I would like to come and see the place before I donate anything. So I said, all right, please come. Time set, date set. Mr. Winternitz in his suit and his tie. He was a small man, but typically Germanic person. He came at the right time. Now, the trick was, told all my boys and girls, at this time, you stop all the sedation that you are giving him. Stop the Valium, stop everything. Let them convulse like mad. So Mr. Nitz walks in, I could see him sweating like a pig, because it was so hot in that room. We had a table for him, we had a chair for him. And he sat down and he looked at her. I could see he was absolutely about to faint. Then I said to my just bring the tea, the JJ hospital canteen tea, which is, we were used to it. But poor Mr. Winternitz, the tea was put and some biscuits were put, Mr. Winternitz, please have some tea. So Mr. Winternitz, with a trembling hand, took the tea and he almost vomited and put it down again. He said, Mr. Winternitz, you see, we need ventilators. He wanted to get it. Oh, yes, we'll go. Let me go now, let me go. I got my ventilators. And there was a fellow in Tata's, Volta's chairman, who was a very sweet man. And I went up to him and said, we need to have this room ventilated. Please, can you do that for us? In a minute, he just said yes. Tatas in those days were even better than what they are now. Just said yes, without a word. I'll air conditioning. So we had air conditioning, we had ventilators. The thing was now that there were just 3 ventilators and there were 8 patients. So I would put them on the 3 worst patients. But what about the others if they took bad again? So it was a bit of a nightmare for me. So I approached the breach candy and said, please, will you allow me to put these very sick people in our unit? Amazingly, they were lovely trustees in those days without a moment's hesitation. They said, all right, do that. So in the 8-bedded unit that we had, very often 3 or 4 were occupied by these poor tetanus patients. Now, shall you show me the tetanus things? Can you show them to me? Did it come? Yes. This is our tetanus patient. These are people really from the streets. You can see how bad he is. The first thing that we had to do is to scrub them clean of the dust and mire so that they were not infected. And you can see that, this poor person, you can see how wasted he is. There's another interesting thing I learned, which I don't know if you all are aware of, that in these very sick people, you may feed them 3,500 calories, but they never absorb them. It's an interesting thing, and subsequently it was been found and shown that even in critically ill people, you don't need usually more than 1,500 calories. Overfeeding them does them more harm than good. My wife used to make lots of concoctions, which they could put through in the nasogastric tube, but they didn't put on, they would continue to lose weight. Either they died, or if they recovered in this state. This boy, of course, recovered, and you can see how thin he has been. So that was tetanus, and it was one of the most gratifying things at the JJ that I have done. Can you show me the results? This is tetanus neonatal. Now look at this. The mortality at the JJ hospital overall was 30%, and grade 3, grade 4 fulminant tetanus was 100%. And after 1982, we had 150 patients. The overall mortality had fallen to 12%, and severe tetanus was down to 23%. It was a motivation game. You see, the nurses were there. The boys were there for 48 to sometimes more than 48 hours without anything. in the ward. A cup of tea stashed there, biscuits eaten there. We had a big board put up saying, so many patients, these are the complications, this is the mortality, and they were told, you have to improve on it, you have to improve on it. Every day after my rooms, I would go back to the tetanus ward and be sitting there sometimes till 11 o'clock at night looking after patients, where my poor wife used to fetch me. We would be sitting in the Fiat car, which is used in those days. There was no air conditioning. It was steaming away inside. So that was how it was. And the children waiting there, not having dinner, they're refusing to have dinner because mom and dad are not there. So that is how it was in those days. So this is how I think this was the best thing we've ever done. And the very, very ill people, for example, where there were no ventilators left for them because they've been used up, I shifted to Breach Candy Hospital. And there, the mortality, if you look at it, was fantastic. Overall mortality, no, this is the overall mortality in all said and done. In the 32 patients in Breach Candy Hospital with fulminant tetanus, with perfect critical care, only 2 died. One died suddenly, who was well and he suddenly died, and another had acute respiratory distress syndrome and died as a result of that. So that was a very good thing that we managed to do. So this is, and I want to tell you what the situation was in the city. It was terrible. For one thing, once intensive came up, so many of these unscrupulous doctors would have small cubby holes and call them intensive care, had 2 beds in them. Patients would be put there. They used to die there. There was no concept of what critical care could be. That was an extra, and it was also elsewhere in the country as well. They had no concept of using a ventilator. A ventilator was used as the last stop before the patient left the world. If the ventilator was used, it had to be removed quickly remove it, so that, the patient, when recovering, with the ventilator taken off, and the patient again become as bad as possible. So it was a dreadful state of affairs. I remember going to Calcutta once to see somebody who was not known to be, who was known to a friend of mine. And he had his ribs fractured after an accident. I asked the hospital, it's very simple, just intubate him and put him on a machine. You put him on the ventilator, he'll be well after some time. You need to put him on a machine, ventilator, because his ribs are cracked, and you need to make sure that when he breathes, the ribs don't go in. So he said, no, I don't have a machine. So we rang up 6 places in Calcutta. One would say, yes, I have, but then ring back and say, don't come, I've sent it for repairs. There was no ventilator at all. Then I said, well, ask the orthopedic surgeon to put clips here, take a pulley and keep the ribs in place. But the poor fellow died. I remember that extremely well. So that was the situation, as bad as that. Till ultimately things started to improve, till the Critical Care Society came up. They started taking exams for people so that the people who came out from their training, at least, they knew what they were doing. So that is how ultimately things started to improve. Now, give the next slide. Now, I just asked myself the other day, no, not this. No, wait, just wait. I'll tell you. I asked myself, what good have I done? Or what have I achieved, or what good I have done? And I was just thinking about it, and I said, well, first I started something and nourished something as best as I could. Second, I taught innumerable number of generations of students. That was a worthy thing. And all of them are beautifully placed just now, all over the world. So that was the second important. Third, I said I set up a unit which was reasonably good. And I said it could compare to the units outside the country. And, it's important to compare. And you can't compare my mortality so much and your mortality so much. You have to do that only by knowing what is the degree of your illness. So for one whole year, we so far scored all our patients. And when we saw the results of others, and we found that our SOFA scores and our mortality in patients who had high SOFA scores was as good as those in the West. And another thing I showed, which was very seminal, I think, at that time, it was that the mortality for multiple organ failure in tropical infections was far, far less, even though the SOFA scores were very high, like tetanus, like dengue, like severe malaria, severe leptospiral infections, severe fulminant amoebic infections, all such tropical infections in patients who were desperately ill, with so far scores going up to 14 and 15, which would ordinarily die with a gram-negative bacterial sepsis. In these tropical infections, when they are there, they still survived. Particularly in those days, you now don't see that bad malaria. When malaria was rife, and you had all organ failure, and yet the patient could survive if you looked after him well in a critical care unit. So that's the other thing that I ultimately was able to show. And I used to make profuse notes of what I had seen at home and on the paper, on the patient's paper as well. And these I distilled and put down in writing in books. This now shows, this is the first book before Critical Startup. It was with a dear mentor of mine, Dr. Rustam Jal Wakil, who was a cardiologist. He was a wonderful human being and an excellent clinical cardiologist and a great gentleman. In those days, there was a lot of backbiting against this nice man, but he never said a word bad about his opponents. Not a word would come out from him, even though he was very nastily treated by them, by many of them. So this was the first book that I wrote. I was very fond of medical. That was, I think, 1972, and the last edition was in 1988. It's the second one. And this, of course, was something which I did with the Oxford textbook. Tetanus it is the classic sort of, I wouldn't say guide, but the classic sort of book in relation to tetanus, which is there by, and I was invited to write on this in the Oxford textbook of medicine on 2 separate occasions, as also on the concise Oxford textbook of medicine, or the big Oxford textbook of medicine on 2 particular, 1994 and 1995. Next one, please. And this is the first book of its kind in our country, and probably the 3rd book of its kind in the world. There were 2 other books on acute respiratory failure. This is my personal experience of acute respiratory failure, and it was the first time that the acute adult respiratory distress syndrome was described in this book. And the next one. And then Principles of Critical Care. I distilled what I had seen, what I had observed in my country, in my patients in this book, and it has become the standard textbook now. And this is the Principles of Critical Care has now witnessed its 4th edition, which is quite remarkable. It's a nice, very nice book. It's completely different from Western books, for one thing. It's written in a rather better style. It's not sort of dry, but quite interesting. Is that all? That's all, I think, nee? And yes, of course, respiratory medicine, that's one of the first books. There are only 2 books of this kind in India. This is mine, and it's quite a useful book at that. Now, I'd like to just say, are there any comments that I would make? The first comment is, for people who are in critical care here, that empathy and compassion are as important as your expertise. I think you should all remember that in any field of medicine, that holds true. The second thing is, don't behave like a god in these units. You can't say, I think, let this man go, let this man live, No, use your common sense, but treat everyone well. That's the second very important thing that you should use. And treat everyone equally. That's so important. If you are a physician or a surgeon and you treat a VIP different from an ordinary man, you're no good. And you'll never be a good physician or never be a good surgeon. I remember one particular patient I talked of, he needed a tracheostomy. And there was tremendous madness. How, if he dies, what will happen? What are you doing? What are you doing? I said, damn it, this man requires a tracheostomy. He's got lots of secretions. He's too feeble to cough. He must get a tracheostomy. No, if something happened, I said, so what if something happened? We are doing the right thing. You see, that's what I mean. You can't treat people differently just because he's rich, powerful, or moneyed. That's so important too. So these are the things You know, and unfortunately today it's a little different. It's a little different. Medicine has lost its human touch. Its raison d'etre, which is the French for reason for being. It's lost its humanity, its human touch. Today I sometimes see doctors talking to the registrar, looking at reports, and not even touching the patient. Not even touching the patient. Leave aside, not even talking to the patient. An intelligent man will say, what the hell? I mean, I'm paying such a bloody cost for this, and this man, he doesn't even look at me, doesn't even talk to me, doesn't even examine me. This is what medicine has come to. And that's the reason why medicine is getting a lot of flack for that reason alone. So that's what I think it is. But you know, when you deal with very ill people, and if you like somebody who's very ill, which has happened because you're human, you like a patient because he's so good, he's so brave, he's so nice, even when very ill, he's so gentlemanly. You found a bond with him. You have a bond with him. Faith, trust, and bond. And when such a person dies, it hurts you. You get a scar. So I said to myself, my heart has many scars for that reason alone. But it still beats. I don't know why. It still beats. I told my son that the other day, and he got annoyed. That is what I would like to say. So also sometimes I honestly feel as I get older and older, things sometimes seem to me preordained, almost predestined. You know, what is to happen is to happen. And we poor earthlings are fiddling around and running around like circles, trying to do this and do that thing. Look what we are doing, look what we are doing. Some of you must have heard of Umar Khayyam, haven't you? Anyone? No? I'll give you a beautiful quote. The moving finger writes, and having writ moves on. Nor all thy piety nor wit can draw it back to cancel half a line, nor all thy tears wipe out a word of it. Thank you.
Thank you so much, sir, for such a thought-provoking talk. We now request Dr. Ashok Shaha to come on the dais and hand over a token of appreciation to Dr. Farokh Udwadia, sir.
Good afternoon, everyone. It gives me great pride to be a part of the launch of this book, The Submental Flap in Oral Cancer Reconstruction. The book is a culmination of collaborative work of Dr. Sultan sir, Dr. Kannan sir, and all his students, with a goal to offer a focused practical guide on the submental flap. Despite being described years ago, the submental flap remains underutilized in many regions, often overshadowed by free flaps or other pedicled options. Yet, it offers a reliable solution without requiring high-end microsurgery. It's especially valuable in settings where resources are limited or where patients may not be strong enough to undergo longer procedures. In this book, we explore detailed anatomy, oncological considerations, particularly the debate around the level 1 nodal involvement, and technical refinements that have evolved over time. Whether it's a question of oncological safety or its place in the era of microvascular dominance, these are addressed transparently and with surgical honesty. Our goal with this book as a whole is to make the technique approachable and applicable, whether you are a trainee or an experienced surgeon exploring alternatives to free flap reconstruction. We hope this book serves not only as a practical guide, but also as a catalyst to reconsider this versatile flap, especially in settings where resources and or patient comorbidities demand flexibility without compromising patient outcomes. To the readers, especially the head and neck surgeons, I hope this book empowers you to innovate responsibly, question peacefully, and always keep learning. Thank you once again, sir, for making me a part of this journey, and thanks all of you for being here. Thank you.
Good afternoon, everyone. Thank you all for being here today. So my colleague Dr. Mohsin spoke about the book. I'd like to say a few words about two of its authors, my teachers, Dr. Sultan Pradhan and Dr. Rajan Kannan. From them, I have learned that surgery is not just about technique, but about discipline, humility, and compassion. For decades, Dr. Pradhan has been a towering figure in head and neck oncology, a pioneer whose work has shaped the way these cancers are treated in India and across the world. This book is very much his vision, and it reflects his effort in refining and establishing the submental flap as a versatile tool in the reconstruction of oral cavity cancers. Apart from this, I would also want to highlight someone who often chooses to stay away from the spotlight, Dr. Rajan Kannan. He is among the most humble people you will meet, yet an outstanding surgeon with a solution to every problem. In the operating room, very often we are faced with a problem. At that time, we pause and we ask ourselves, what would Kannan sir do? And invariably, that thought shows us the way forward. This book is especially relevant in our country where the burden of oral cavity cancers is so high and not every patient has access to microvascular free flaps. The submental flap offers a safe and reliable option, one that is practical in our setting and helps us treat many more patients effectively. What I have contributed here is rooted in what I have learned from my teachers, and it is with humility that I carry their ideas forward. I feel deeply privileged to be their student, and I hope this book carries forward their legacy for the next generation of surgeons. Finally, I would want to thank my wife Aditi and my daughter Rhea for their love, patience, and support. Without them, none of this would have been possible. Thank you.
Thank you, sir, for sharing your wonderful experience. Now we call upon to unveil the book. We request Dr. Pradhan, Dr. Shah, Dr. Farokh sir, Dr. Sharmila madam, Mr. Yejdi Maligam to please come on the dais and do the unveiling of the book. We also request Dr. Kannan sir to come on the dais. Thank you. Thank you so much, sir. I also request all the delegates to take their complimentary copies of this book from the registration counter. So now we break for a well-planned, well-earned lunch. Please be back by 2:30. It's a humble request. Thank you so much. Panel discussion on medullary thyroid carcinoma. So we request Dr. Ashok Shah, sir, to moderate this session. Sir, we request you to please come on the dais and take the seat.
We will briefly introduce each of our panelists. Dr. Baman Dabar, a hardworking medical oncologist with vast experience. He is widely respected for his patient-centered approach, clinical excellence, and academic contributions. We welcome you, sir.
Dr. Roshan Chenoy, Head of Department of Histopathology and editor of HNCII newsletter. With decades of expertise in oncopathology, she has made histopathology easier for surgeons to understand. We welcome you, ma'am.
Dr. Sharmila Agarwal, Head of Department of Radiation Oncology at HNCII, with 30 years of rich experience in the field. She is also a teacher and guide for postgraduate students of radiation oncology. We welcome you, ma'am.
Dr. Asif Momin, Head of Radiology Department at HNCII with specialization in interventional radiology. His guided needle aspirations are almost as good as biopsies. So no wonder our pathologists and surgeons could not do without him.
We welcome Dr. Ashwini Kalshetty, nuclear medicine physician at HNCII. We are honored to have you, ma'am, with us.
Dr. Mohsin Sheikh, he is an experienced head and neck surgeon who has honed his skills under the mentorship of Dr. Pradhan. He has an invaluable experience in the management of complex head and neck surgeries. We are pleased to have you, sir.
Dr. Kanav Kumar is a skilled medical professional specialized in surgical oncology. He is trained under the guidance of Dr. Sultan Pradhan. He has further honed his skills in advanced laser surgeries for laryngeal cancer through training in Genoa, Italy. We welcome you, sir.
Now we request all the dignitaries to begin the session. Thank you.
Okay. Well, while he's bringing up the slides, let me just tell you, medullary thyroid cancer is a very interesting disease. And the way I see the panel here, the surgeons against everybody else. It's a surgical disease. The better surgery you do, the better results you get. That's why we always say, remove the medullary thyroid cancer, the last milligram, you will get the best result. What I'm going to do is, first 15, 20 minutes, I'm just going to bring up some discussion about the controversies. Okay, so I'm going to take 10, 15 minutes, just give you some controversies and the current perception, what is going on in the United States related to medullary thyroid cancer. This is one disease where we really, really need a multidisciplinary group. You can't be alone taking care of this patient. You need a good nuclear medicine, you need radiology, you need the new field, medical oncology, has revolutionized the management of medullary thyroid cancer and anaplastic. We'll be talking about that later on. But it has really revolutionized the whole approach towards medullary thyroid cancer. Okay, so let me just, these are the revised guidelines. The first guidelines were published about 10 years back. Now, why do I show this slide? There is a reason behind showing this slide. That there are many people involved in the medullary thyroid cancer. The person who was directly involved was Sam Wells. I don't know if you know. He was a chairman of surgery at WashU. Right now he's not well, but be that as it may. He made enormous contributions, and he was the first surgeon to promote RET mutation studies. And he was the first surgeon to write a paper in 1994, Annals of Surgery, his experience with prophylactic total thyroidectomy. This is the only disease where a prophylactic surgery will prevent development of cancer. And I think this is very important. These are the changes that we have seen in medullary thyroid cancer. So I just wanted to show you the second edition that was published in 2017. They're working on the third one, which will probably take another couple of years, but it will come up. So I don't want to go in the details, but you can see here the flow chart of the landmark discoveries in the management of medullary thyroid cancer, and you will see here from, I'm taking it from 1985, not 1949 when the diagnosis was made, you know, the first diagnosis was made in Cleveland Clinic. That's where the disease started, but we have made enormous progress here. And as you will see here, the last 10 years, there have been a lot of new drugs coming up. And the most recent drug that has been used is selpercatinib. And I'm sure we'll hear from our medical oncology colleagues. I don't want to take the thunder because that has really revolutionized the approach towards medullary thyroid cancer. So one of the most important thing in medullary thyroid cancer is genetic testing. Let's say I'm going to make it simple. I have medullary thyroid cancer. You are my doctor. You got to do my genetic testing. And it is not for me alone. You will be able to get some idea what kind of medullary thyroid cancer I have. Is it aggressive or not? But for my family, for my children, for my grandchildren, for my parents, my brothers and sisters. Because if I'm genetically positive, they need to be studied. If they are positive, they need prophylactic total thyroidectomy. Again, there is a lot of controversy about it, but I think everything is very clear that the genetic testing is very necessary and important. The plasma metanephrines, we always do that before operating on medullary thyroid cancer because it could be a part of the MEN syndrome, and you don't want to miss or bring the patient to the operating room with pheochromocytoma. And at the time of anesthesia, you will find the blood pressure shooting up to 250. You know that you miss the pheochromocytoma. The serum calcium and PTH levels are very important to make sure you're not dealing with a parathyroid problem. It is not very common that it will be presenting with medullary thyroid cancer. It is over a period of time, you may develop hyperparathyroidism. And as I mentioned before, the family members need to be studied. The serum calcitonin is very, very critical. If you draw my serum calcitonin today, and it is 500, you can practically write on a piece of paper, Dr. Shaha, you have medullary thyroid cancer. Am I correct? I think everybody will agree with that. There are very few other organs which will produce calcitonin to that level. Sometimes the pancreas does, sometimes brain tumors, but those are generally about 20, 25, not more than 100. So, and the CA, we always like to do it. I think it is another tumor marker for medullary thyroid cancer, not as strong as calcitonin, but we do use that, especially in poorly differentiated medullary, where the CA may be sky high, but the calcitonin may not be sky high. Okay, the neck ultrasound is very critical for all thyroids. I think the neck ultrasound is very important. The nodal disease is better seen on a CAT scan. Let me make it very simple. And I learned this from my chairman, Murray Brennan. Patients with medullary thyroid cancer presenting with nodal disease are unlikely to be cured. They will remain with mild, persistent hypercalcitonemia. I think I learned this from him about 30 years back, but that message has remained in me. When you see a patient with medullary thyroid cancer with 10 positive nodes, you know he's not going to be cured. He will live long life. He will live normal life. But biochemically, he is unlikely to be cured. So we like to get, always like a CT scan. Medullary thyroid cancer is more likely to go to the paratracheal lymph nodes and superior mediastinal lymph nodes. As a matter of fact, there is a very famous surgeon, Henning Drala. He is in Germany. He's an endocrine surgeon and a thoracic surgeon. he always opens the chest because he knows there is a disease there. We don't do that routinely. We do that only if the patient has recurred. But when the calcitonin does not come down, you know that the disease is probably in the mediastinal or the liver. The liver metastases are difficult to find. There's no imaging study that is very powerful. But at one time, about 20 years back, Sam Wells and his group were doing peritoneoscopy to find the liver metastasis. Because these are the surface metastases, they are miliary and you can't get a good diagnosis with any of the imaging. Unfortunately, it didn't become very popular because, okay, you have liver metastasis, what are you going to do? That time we didn't have the drugs, so there was nothing we could do, so it didn't become very popular. Dotatate, I think we'll hear from our nuclear medicine colleagues a little more, but we do it only if the burden of the disease is very high. For early stage medullary thyroid cancer, we don't do the dotatate scan. One of the debate that comes up, and I think this is a surgical debate, and even in the United States, we always argue about it. You have a patient with a 2 centimeter thyroid nodule. You do the ultrasound, you do the biopsy, etc. Should you do a calcitonin on day 1? Means, is there a value of doing calcitonin? At least in the guidelines, the 3 guidelines that were published, American Thyroid Association, they did not support routine calcitonin. Now, if you go to Italy and Europe, routine calcitonin for thyroid nodule evaluation is common. And that was because of the enormous effect of Aldo Pinchera, who was an Italian endocrinologist who wrote the guidelines for the Italian group. And he strongly felt you should do the calcitonin. We don't do that routinely unless the needle biopsy is something atypical or the pathologist tells, look, I don't like this, something bizarre. The word bizarre means you're probably dealing with medullary thyroid cancer, because that's the only histopathology where you get the funny results. Okay, so the RET mutation is very important. This was published by in the guidelines, which is the highest risk, 918. That's where I will show you the slide, next slide. But the prophylactic surgery is done much younger. As a matter of fact, it is written in the books that you should do it as soon as you get the testing done. Below the age of whatever, 6 months, 1 year, 2 years. The problem is, it is a difficult surgery. Doing the prophylactic total thyroidectomy in a child is extremely difficult. The nerves are very small. The risk of nerve injury and the parathyroid problem is very high. So be very careful. The high risk is 634. The moderate risk, all the others. And the low risk is 768, 790, 804. 804 is a very common mutation we see in the United States. One of the questions that comes up is, when do you do the prophylactic surgery? And the answer is here. For highest risk, the first year of life. Or I can change it, the minute you have made the diagnosis. The high risk at the age of 5. Why 5? It was just a thought process. There was no good reason. By 5 years of age, the thyroid gets a little bigger, the parathyroids are easily identifiable. But is there a golden rule of 5? No. Can you do it at 7? Yes. We had several patients who came at the age of 5, 6. We didn't operate because their calcitonin was normal, ultrasound was normal, and the parents didn't want their kids to go through total thyroidectomy, thyroid medication for the rest of their life, and some accompanying complications. For the moderate risk, anytime after the age of 5. That's what our general philosophy is. The major question comes, and we have faced this. One of the parents has medullary thyroid cancer at the age of 60. And there are 3 kids who are at the age of about, say, 35 to 40. So I'm going to get the opinion from the panel. What would you tell the 3 kids? The 3 kids are healthy. They are in 30s, 40s. They say, my mom had medullary cancer at the age of 65. Sorry? Rate positive, yes. 804. 804. That's why I started with the 804. Not a high risk, but it is a risk. At what age do you want to operate now? They are all 30-year-old.
Diagnosis there, if calcitonin levels are high,
Yeah.
we should do it.
Yeah,
That's
you know,
my
I mean,
guess, that's a common sense guess.
right. You know, what he said is absolutely correct. I think we would consider doing the surgery. We'll explain the patient that your mom developed medullary cancer at the age of 65. We don't know what will happen to you between 30 and 65. But the one problem is, if the medullary thyroid cancer develops, genetically development, and then they get nodal disease, it's bad syndrome. I think it is not a good problem. It's not, the overall outcome is not very good. So this is the classical picture that all of you are quite familiar. It's there in every textbook after Eng's publication in JAMA, the prophylactic surgery. And these are all the codon mutations you can see there. And at what age you should consider surgery. Generally at the age of 5 years is generally considered to be the ideal timing to do the prophylactic surgery. Okay, now how does the serum calcitonin predict the nodal disease? Now, this is the work from Henning Drala. You can see here Markans and Drala from JCEM. These numbers are probably much lower than the reality of life. He has written that if the calcitonin is more than 200, you have contralateral nodal disease. You don't see that very often. There is a paper coming out from China, and their numbers are much higher. Here you will see he has written about if the calcitonin is more than 20, they are ipsilateral neck nodes. I don't think any one of us will agree with that, because you do get calcitonin from the tumor itself. The nodal disease is a secondary. And unless the calcitonin is like 800 or 900, I probably would not be more concerned about it. Okay, so I'm just going to make comments about two new aspects of medullary thyroid cancer. This is, I think, we'll ask our oncopathologist also about desmoplasia. Henning Drala has written quite a bit about it, looking at the thyroid tumor and desmoplasia. If there is no desmoplasia, you can see the last line. Desmoplasia negative tumors are very well treated with lobectomy alone. Means desmoplasia is a good indicator to give you the grade of the tumor. Now the problem is, we talk to our pathologists who are very good. They don't believe in it, because they say it is difficult to interpret desmoplasia. But Drala group always feels they can do the desmoplasia on frozen section. I'm not sure. Do you have any comments?
Yes, we do observe desmoplasia, and quite honestly, when we do frozens, we take more cellular areas rather than hard areas, because we want to see the cellular content. And in frozen, we would take 1 or 2 sections, whereas in the final, we would take 8, 9 or more.
Yep.
So desmoplasia, we study better in the finally resected specimen.
But you know, I think we go along with what you say. That's why we don't look at the desmoplasia in our center. But his group, Drala group, strongly feels about it. And he also writes, and you will see the recent publication in the last 2 years, the desmoplasia negative patients have less aggressive medullary cancer. And there is a old dictum that medullary thyroid cancer requires total thyroidectomy and central compartment dissection. I think we are going away and away from that. If there is a RET mutation negative, we don't do total thyroidectomy. Sporadic medullary thyroid cancer, lobectomy is enough. This is a major paradigm shift in the management of medullary thyroid cancer. Okay, let me just go. I don't want to go in the extent of surgery. We talked about it. Total thyroidectomy and central neck dissection was the dictum before, but we don't use that very often now. Unless it is a genetic disease, we don't do that. Or radiologically proven disease on the other side. We get a good ultrasound, we do CAT scan, that tells us what is going on in the opposite lobe. Okay, so the extent of thyroidectomy for familial and sporadic. There is a big difference between familial and sporadic. If it is sporadic, means no genetic alteration. We are very comfortable with lobectomy as long as the opposite lobe is normal. And there have been, actually it is interesting, Akira Miyawuchi from Kobe, Japan, the person who started active surveillance, wrote a paper in 2008 on lobectomy for non-familial medullary thyroid cancer. We didn't pay attention to that, you know. Nobody followed with him. And now there is a lot of interest. The Wu is one of our fellow now in UCLA, is trying to do the prospective study on that. I had an opportunity to write an editorial on this subject, and there was a lot of interest from around the country about doing a lobectomy only. Keep in mind, you have a very powerful tumor marker for medullary thyroid cancer, and you can follow that. If that goes up, you know that the medullary thyroid cancer has come back. Either it has come back in the opposite lobe or the lymph nodes, and try to find out where the recurrence has occurred. Okay, so I'm just going to take this, and then I'll stop with one more slide. There is always a debate whether we should do the prophylactic lateral neck dissection. And there was a paper published from Memorial and one from MD Anderson negating that philosophy. If the ultrasound doesn't show anything, your CAT scan doesn't show anything, and at the time of surgery you don't find many positive central compartment lymph nodes, you can avoid doing a lateral neck dissection. Now, if you ask Henning Drala, he will be very angry at me because his whole career he has been doing a prophylactic lateral neck dissection, and he goes to the level of doing bilateral lateral neck dissection. That's too much on the part of the surgeon, you know. I mean, you get exhausted. You can't do that operation that very often. Okay, so I'll finish here. I think all of you are quite familiar with prognostic factors. I won't go in the details. These are the prognostic factors. Let me just show you one thing. Persistent hypercalcitonemia is a problem. Where is the recurrent disease? And the recurrent disease can occur at three places. Either in the thyroid bed, number one. If you have done a lobectomy, it may be on the other side, number two. Number three, lateral lymph nodes. Number four, central compartment or superior mediastinal lymph nodes. And number five, liver metastasis. These are the areas in that order where the recurrent disease may be. Persistent hypercalcitonemia does not mean it is a kiss of death. Patients will live with mild hypercalcitonemia for a long time. Unless there is a structural disease, we just monitor the patient, see what happens. And Akira Miyawuchi has published a very nice article on calcitonin doubling time. If the doubling time is less than 2 years, it is a bad sign. If it is more than 2 years, patients will do well. I think, again, the whole idea is what is the volume of the recurrent disease? That's the bottom line. Let me just take one more and I'll stop here. Okay, so these are the newer drugs. I think they are very familiar. Selpercatinib. Lori Worth wrote a very nice paper in the New England Journal of Medicine. Whenever you give a talk, there should be one slide with your name on it. You saw my slide, you know, Wu, Miyawuchi, Wu, and Shaha. You feel good, you know, you are in that group of Miyawuchi group. And the second slide, there must be one slide from New England Journal of Medicine. If you want your talk authentic, you have to have a slide from that. There is something between the lecture and New England Journal of Medicine. It becomes a very authentic talk. So this is a new drug. There are many drugs coming up. One is Pralsetinib and Selpercatinib. You know, this is a very complex name. Why don't you make it simple, like Shaha, you know? Why do you have to have the name Gadhinglashkar? You know, very difficult. They have Shaha, you know, very simple name. They don't do that. Okay, so this is, let me just, okay, you can see here, take a look at each slide. They are comparative slides. I can't use my pointer right now, but you will see the considerable diminution of the medullary thyroid cancer. And the two diseases where we are using it now, one is medullary thyroid cancer and another is anaplastic. And let me tell you, the inoperable, incurable diseases where the surgeon felt, I cannot do anything, the tumor volume reduced so much that we could operate on them. So this is truly a major advance or paradigm shift in medullary thyroid cancer. Okay, so this is my last slide. I just wanted to show you, because this comes from Memorial. Bin Shu is one of our pathologists, and she came up with the new risk stratification. So which are the risk stratifications? One is tumor necrosis, very important. It is also very important for anaplastic thyroid cancer. The second is mitotic index. You know, how many mitoses are there per high power field, and Ki-67. There's a lot of debate about Ki-67. Some pathologists agree, some don't agree, but that is always going to be there because these are the prospective studies done in our institution. So I'm going to stop here and give chance to each one of the panelists before we go to the cases about their comments. Let's start with you, sir.
So, we don't have really access, sir, to self-presidenib, and we don't have easy access to self-presidenib. One of my patients who was RET positive CA lung, he also could not get it. Means it was phenomenally expensive, sir. To get self-presidenib is impossible or very, very difficult. In fact, just as a comment, I'm saying he got it from Bhutan or somewhere he got it. And he showed me some Bangladesh somewhere, the generic one. And I said, okay, start that. At least something you have got. So yes, sir. So this was a lung cancer patient, sir. So there is in lung it is RET fusion, and here it is RET mutant. So RET fusion also it works, RET mutant also. And so pralasetinib, just as a comment, it has been withdrawn empirically now for use for medullary carcinoma. The company has only withdrawn it now. What we have access here is cabozantinib. So if you have used it, I don't know, we have the Indian brands of cabozantinib also. So we have used cabozantinib. But again, sir, there are different versions of cabozantinib that we are supposed to use here. In medullary, we are supposed to use a liquid form. It is some different brand. What we have in Indian one is mainly for our renal cell carcinoma, but we have used that sometime.
The one big difference between United States and the rest of the world is the insurance covers these drugs. Even though it is prohibitively expensive, the insurance is willing to cover. And that's part of the reason you see the progress. You know, when we see an advanced, inoperable, incurable medullary cancer, we don't mind putting them on selpercatinib and seeing what happens. Comments from pathology point of view?
As a diagnostician, cytology sometimes definitely helps because we can appreciate the neuroendocrine features in the nucleus.
Yeah.
But when the tumor is high grade or poorly differentiated, that's the time when then we try to rely more on immunohistochemistry, like calcitonin, CEA, and the negativity of thyroglobulin. Right. So it's not a very difficult diagnosis in the well-differentiated areas, but it can pose a problem in the high-grade ones.
That's why I use the word bizarre.
Sorry?
That's why I use the word bizarre. When the pathologist tells me it's a bizarre tumor, I say maybe it is medullary thyroid cancer.
Yeah, but then we also think of anaplastic when
Correct.
the word bizarre comes.
Correct, yes. Yes, very important. You know, the Congo red stain that we used to read in the books, I think it is still there. Go ahead.
Sir, it is very important that the surgery is complete in medullary thyroid carcinomas. And if the surgery is R0, I think these are the patients who routinely are not offered adjuvant radiation. Adjuvant radiation is offered very rarely in this group of patients with extensive extrathyroidal disease and a R plus resection or with extensive nodal metastasis. Even in this group of patients, I think we can observe them with serum calcitonin levels and CEA levels. And if they are falling, these are the patients who, even in case they are asymptomatic, can be observed. This is what.
I think her comments are very pertinent because there is a knee-jerk reflex when you see 5 positive nodes. Hey, maybe this patient will recur, let's give radiation. But the American Association of Endocrine Surgeons and majority of the endocrine surgeons completely go with her, that use it very selectively when you think that the future recurrence is likely to be fatal. The tumor recurring on the cricoid cartilage. Because you know the next operation may be total laryngectomy. That's the time I would consider. Maybe I can take the, pick your brain right now. Can you give us the indications for external radiation therapy in well-differentiated thyroid cancer?
So again, the well-differentiated thyroid cancer, the indications for radiotherapy are very limited. These are the patients who are refractory after surgery to radioiodine and have a margin-positive disease or again, extrathyroidal extension. Yeah. Only then these are the patients to be considered, otherwise no.
Yeah. The one place where we use external radiation therapy in well-differentiated thyroid cancer is bony metastasis.
So that's in a palliative setting.
Right.
For adjuvant.
Right, yes. Sir.
I think after listening to all this, we realize we get to see medullary in 2 types. One is sometimes when we don't know in the beginning, and sometimes when we know that patient already has. So in the second subset, when we know there is a disease existing and they come back to us for follow-up, that time we, I think, have a good role where we tend to pick up small deposits in the paratracheal region or the distant sites. So compared to an PTC, these nodes tend to go at little wrong sites. Like PTC doesn't go to level 1 generally or intraparotid, but medullary can go at very bizarre sites. So I think our role becomes little important. And these small tumors are very vascular and they're kind of sticky there and they're sticking to the adjacent area like a small octopus. They're stuck to that some adjacent area and we tend to pick them up. And I think we find it very challenging and rewarding to pick those deposits because calcitonin anyway helps us to know that it is rising or falling, but we do tend to pick up. And once the surgery is done, we tend to follow them up whether there is anything new to be sure that we have done a good job. So
great.
It's important.
Go ahead.
Hello, sir. So from nuclear medicine point of view, we have a lot to offer, especially in the Indian scenario with the advent of, the upcoming adoption of theranostics. So we have the diagnostic component where we use the somatostatin analogs for DOTA-TATE, DOTA-NOC, NOTA, all the gamut of somatostatin analogs, PET-CT, as well as DOPA PET-CT has shown promising results from diagnostic point of view. And in therapy domain, systemic therapy, I think we have promising results from various groups, although they are heterogeneous population, but we do have the availability of MIBG therapy as well as DOTA-TATE, PRRT therapies.
Okay. So we've got 2 surgeons. We always keep them last, right? That they have the final word. So go ahead. Let me just ask you one question. Are there any features of a thyroid nodule, either on ultrasound or CAT scan, that will make you think about medullary cancer? Is the question clear?
Yeah.
Okay.
I think so. That's what I meant. When we don't know that this could be a medullary or papillary, there can be somewhat confusion, but we try to resolve it in a certain way. And those features are dealing with, one is the primary nodule and the metastatic diseases. So in general, the primary nodule of medullary tends to be very well defined, solid. It's more echogenic compared to the PTC, which tends to be having more cystic areas and lot of sarcoma calcification, that the punctate echogenic foci. So that's clearly missing in medullary. So that warns us that it could be one. And so much so that it sometimes looks almost benign on thyroid's grading. And only when we apply color, it really robs the whole thyroid. The entire tumor takes that vascularity. It is so vascular. So that allows us. And on the metastatic part, the nodes also look clearly different from the PTC because they are more larger and they are solid and less necrotic. So they look little different. So I think by this we tend to say this could be medullary, and then sometimes we tell patient before medullary, when we suspect, we ask them calcitonin and then try to get a result. So there is definite imaging this thing. And in medullary, we have also possibility of distant metastasis where we don't just rely on ultrasound, then we go ahead, we do cross-sectional because we do see retropharyngeal or odd site lymph nodes. That's the reason.
Excellent. Go ahead, Kana.
Sir, everyone spoke about the advantages of calcitonin, how it is a wonderful tumor marker and we can monitor the patient in follow-up. Something that Dr. Pradhan always speaks about is one of his talks he had taken several years ago, which was called The Curse of the Calcitonin Assay. Because most of these patients will have a rising calcitonin but be asymptomatic. But with this calcitonin assay, now they are worried there is some disease inside and it just keeps worrying them. And when they are asymptomatic with the rising calcitonin, we would probably not even treat them, just wait for them to develop some symptoms.
I think that's always a question. When the patient is already well controlled with the primary surgery or primary therapy, how often you want to follow, or what kind of investigations you want to do. And you are absolutely correct. The calcitonin, post-op calcitonin is 100. What do you do about it? You already cleaned up the neck. The only reason we do this is to see at what stage you may be able to identify a structural disease and attack on it. And that's why I made a comment that post-op hypercalcitonemia does not mean the person is likely to die of medullary cancer. But it does mean there is some lingering medullary cancer which we should continue to monitor. And when it becomes structurally identifiable or easy to take care, then we would go ahead with that. What about you? Any comments?
Sir, like in well-differentiated thyroid cancers, we have radioactive iodine for some residual thyroid if it remains. But in medullary thyroid cancer, total thyroidectomy with central compartment, that means complete clearance of the disease is very important because we do not have any adjuvant treatment for complementary to it.
Yeah, I think, in principle you are correct. That's what all the time we thought about, that the medullary thyroid cancer has one standard treatment, which was total thyroidectomy central compartment dissection. Lately, we have been coming away from that, going based on the pre-op ultrasound, pre-op CAT scan, the genetic mutation, what you have. There is always a debate in the United States because the genetic mutation takes a long time because you have to get genetic consultation to do the genetic mutation. And once it goes to the Quest lab, it takes about 3 to 4 weeks. And majority of the patients don't want to wait that long. They want the surgery yesterday. So all that we do is metanephrines. If the metanephrine is negative, means there is no pheochromocytoma, we're very comfortable operating on the patient and do whatever is necessary. And that's where the debate comes. Is lobectomy a standard of care for medullary thyroid cancer? Probably not proven medullary thyroid cancer, but if you know it is a non-mutated or non-genetic, I think I'm very comfortable with lobectomy. But again, this is a matter of debate. That's why I was saying that Dr. Wu is trying to do a prospective study from many institutions. But we, at least at Memorial, there's one other entity. Maybe you can comment on that. We have seen medullary thyroid cancer, encapsulated medullary thyroid cancer. This has not been described very well in the literature, but it's an encapsulated variety. We take out the one lobe, the calcitonin comes down within 48 hours from 500 to 5. Any comments on the encapsulated variety?
I don't recollect too many with encapsulation, but I do know circumscription.
Yeah.
And there is one situation which I heard in Calcutta where a patient had high calcitonin, but nothing in the thyroid. There was no tumor. And after investigating, it was found in the larynx to have a nodule which was a neuroendocrine tumor producing calcitonin.
Right.
That was an odd situation.
Yeah, that's pretty rare. You know, I operated on a patient with hypercalcitonemia, did total thyroidectomy. And the final report was there's no medullary cancer there. And then later on we found out that his pancreatic tumor was producing calcitonin. You know, but that's probably one case in your lifetime. You know, you're not going to see that very often. For all practical purposes, high calcitonin means medullary thyroid cancer, for all practical purposes. Okay, any other questions from the audience? Prathamesh, you have some very good experience with medullary cancer. I'm curious to know about the encapsulated thyroid. That's a great question. We have about 8 or 9 patients with encapsulated, means you do the ultrasound, you do the CAT scan, you see a nicely well encapsulated lesion, and we have done a lobectomy on them with calcitonin as high as 500. Next day the calcitonin comes down. You know, the standard teaching of calcitonin, post-op calcitonin assay is 1 month. The nadir, real nadir occurs at 1 month. That's not true. I've been sneaking in to do the calcitonin next day to learn more. And I have found out the calcitonin does come down remarkably to about 48 hours. Because the half-life of calcitonin is not very long. The CEA takes a long time. The CEA does not come down next day or the following day. It takes 4 weeks. So in this encapsulated variety, there is a nice capsule. There are no adverse pathological features. Ki-67 is very low. So you know these are well localized, well differentiated medullary cancers. And as I mentioned before, we have a powerful tumor marker. You can follow that. And the calcitonin goes up, then you find where the disease is and take care of it. But that's not the standard description of medullary thyroid cancer. The new guidelines will come up with a suggestion that in non-genetic medullary cancer, you may consider doing a lobectomy. There's a lot of interest in that now. Okay.
Sir, for calcitonin, what imaging do you prefer? What imaging do you do at frequency when patient comes for follow-up?
Okay, so
what do you prefer?
You're talking post-op or pre-op?
No, post-op only.
Post-op, okay. So the question is, how often you do the imaging and what imaging you do?
That's right.
I'll make it simple.
Absolutely.
We do the calcitonin every 6 months along with CEA. If the calcitonin is not sky high or not rising, we'll do the ultrasound once a year. We will not do CAT scan for follow-up unless there is a demonstrable rise in calcitonin or there is something suspicious in ultrasound. There is hardly any whole body scan, you know, because the most common area where the disease goes is the liver. And liver, practically, you cannot image very well. You can do the ultrasound, but it's not, because these medullary thyroid cancer metastases to the liver are on the surface of the liver and they are miliary. They are below 5 millimeter, 3 millimeter. That's why at one time, laparoscopy was a common investigation for this persistently elevated calcitonin that you cannot find the disease. But it didn't become very popular. Yes. Yeah, go ahead.
Yeah. Sir, I am not biased or anything, but here PET scan really has a role to play, especially DOTA or DOPA PET scan, because it is very sensitive and it will be very easy to see the liver metastasis or any systemic distant metastasis.
Yeah, you know, I mean, there's a lot of interest in DOTA scan. If you go to China, there is a scan called PAPI, F-A-P-I.
We also have the availability.
It's here, okay. But in Beijing, it is very popular. And they always do that. We don't do that. We do DOTA scan only if the calcitonin is sky high and we cannot find the disease. Then only we do it.
Also, sir, there would be another advantage is to phenotype or the differentiation. More FDG positive when we do multi-tracer studies, FDG versus DOTA versus DOPA. So DOPA is more concentrating in well-differentiated or the neuroendocrine aspect. DOTA will help us decide in the systemic therapies, and also FDG will give us the prognosis. I just wanted to comment.
Yeah, I mean, I don't have much experience with the scan. Our nuclear medicine department,
I'm a nuclear medicine physician. I'll just add to what she's saying. Pre-operatively, when we are evaluating a patient, there's no role of FDG or DOTA. It is only CT scan that you have to do, or CECT is helpful. Only in recurrent cases that we have to go ahead with nuclear medicine studies. And DOTA we do only when we are contemplating to give a PRRT therapy. Otherwise, FDG suffices. Now, if we are looking at DOPA PET-CT, that has the highest sensitivity, but not very easily available and also expensive as compared to FDG. So FDG is the best modality for recurrent medullary carcinoma thyroid when you are looking at a whole body evaluation, and you'll pick up everything. And regarding your liver metastasis, I think if we do a 3-phase CECT along with the FDG PET-CT, I think there are less chances of missing. I don't say we won't miss completely, because then I think MRI is the best. But a CECT along with the FDG PET-CT is a good investigation of choice for recurrent medullary CA thyroid.
Good comments. Very well.
Sir, I have a question for you.
Yeah, go ahead.
Sir,
Don't ask me tough questions.
Sir, have you ever come across a treatment naive patient who has a normal calcitonin level but high CA levels?
Yeah, that's a great question. Yes, we have seen that. We can't tell you the reason behind it, but we have some thought about it, because we always talk about these cases in the tumor board. Why the calcitonin is not high, but the CA is rising. The one thing that goes through our mind is this more de-differentiated medullary thyroid cancer? The well-differentiated medullary thyroid cancer will produce calcitonin and will have excellent results with selpercatinib or drugs. But the poorly differentiated may do that. Do we have good numbers? No.
So when we came across such a case, and therefore we were like, but the patient got operated, it turned out to be medullary CA. One more point regarding when the calcitonin is raised and when the CE is raised. So if the calcitonin is raised, we will go ahead do a DOPA. That would be the best.
Okay.
And when the CE is raised, there are chances that FDG would be positive. So that is, as it goes towards poor differentiation and the CE is rising,
right,
FDG positivity will be more. If it is well differentiated, chances that your DOTA or your DOPA PET-CT is going to be positive.
That's why this is one disease where every specialty gets involved. I think the entire, we talked about well-differentiated also, we talked about anaplastic. I think these are the diseases where we need some help from other people. Yes,
sir, I have a question. Sir, NACT, role of NACT here, do you all practice it normally? And if suppose there are good responses, would you consider somebody who's unresectable upfront to go in for a surgery later?
We use neoadjuvant, whatever you want to call, selpercatinib or pralsetinib. I can say Prakash, but I can't say pralsetinib. We use that only if the disease looks surgically incurable, or we are concerned. I'll tell you when we use it. Clinical problem. When there is a disease in the tracheoesophageal groove on both sides, and you are afraid that you may injure both the recurrent laryngeal nerves, which will end up with tracheostomy. This is the paradigm shift now. We would not treat that patient with surgery first. We'll go with one of these drugs. We've seen good results, and then operate on the patient. As a matter of fact, if the disease is limited only to one side, with very advanced medullary cancer, we're very comfortable not jeopardizing the nerve on the other side and taking out only one side where the disease is, hoping that the opposite side has no disease.
And
Yes.
sir, how long these NA targeted therapies continue, neoadjuvant?
We like to repeat the CAT scan in about 3 months, see the response. If the response is very good, we'll continue for another 3 months. At 6 months, all the specialties will get together and decide, do we want to continue or do we want to operate? And the decision is practically made between surgeon and medical oncologist. Keep in mind, these drugs have some major side effects, and I'm sure we'll ask him the questions about the side effects. And those side effects can be very difficult for the medical oncologist to handle, especially hypertension, GI complications, skin complications. I don't think it's a major problem, but the patients get very upset about that. Yes. Yes, sir.
In continuation of this only, sir, I would like to ask you and Bowman, sir, if we have a patient who has a locally advanced medullary thyroid with no distant metastasis, but in our surgery, we might have to sacrifice one of the critical structures like the tracheal resection or esophagus. Is there any role of neoadjuvant, these TKI inhibitors, which can help in bioselection of the patient, and then we can go ahead later if he responds? So,
Absolutely, yes.
because we many...
You would agree with that? Yes. Yeah. I think, I mean, these are the different flavors, right? But I think that is where we have made a major progress, that we'll be very happy to treat them with neoadjuvant targeted therapies and then see the response. And her question was, when do you analyze the patient? 3 months is a good time, 3 to 4 months. The question comes that at the end of 6 months, you are still unhappy. Then where do you go? And then you continue the treatment for another 3 months, and sometimes you have to bite the bullet and say, hey, it's time to operate.
So,
Yes.
a follow-up to his question, in locally advanced or in a large thyroid mass with proven metastatic disease, medullary CA, would you go for a palliative surgery because of the local symptoms?
This is one of the classical questions that comes up. With the distant disease, how do you handle the recurrent tumor or primary advanced tumor? And there's no right answer. I'll make it very simple on you. If the bulk of the recurrent disease is not likely to kill the patient in a foreseeable time, I would operate on the, because what is going to kill the patient is the local disease. So you got to analyze. Papillary cancer, absolutely, I'm not worried about it. Pulmonary metastasis is very common in papillary cancer. Young people, they have diffuse sclerosing, bilateral bulky nodes. You do the radioactive iodine scan, you will find the pulmonary disease. That is not likely to kill the patient. The only time I would be concerned about doing a major surgery, like laryngectomy, esophagectomy, in the presence of distant disease, which is likely to cause problem, I would probably treat that patient with one of the targeted therapy, see the response in 3 months, and get an idea. If the pulmonary disease is galloping, then there is no point in operating and doing a major surgery here. I think this is the same principle, whether it is medullary or whether it is papillary cancer or Hurthle cell cancer, the same. Any major comments? Go ahead. No, I agree with. It's very rare that the surgical oncologist and medical oncologist will agree. There is something wrong there. No, that's kidding.
Sir, unfortunately, the systemic therapy of ours for this means just on cabozantinib it stops most of the time, sir. Yeah. When we get, we can't use self-pacentinib, sir, because of the cost and all those things.
I see.
So
Okay.
cabozantinib, sorafenib, all those drugs we are familiar with and we use it quite often, sir.
Is sorafenib easily available here?
Yeah, yeah. Sorafenib, sir, and it's absolute dirt price. Cabozantinib also now generic brands are there.
Okay. Any other questions from the audience? Okay. Yes, sir. No, we don't do serum calcitonin next day. No, that's not a standard. That is my interest. Yes, yes. But I sneak it in, because the insurance companies don't ask me, the patients don't have to pay. So when I write the calcium, just write calcitonin, And then when they complain, the nurses always complain to me, why you are getting calcitonin next day. I said, did I write calcitonin? Maybe I made a mistake. But I learned quite a bit, That's how I learned about the encapsulated variety, where you take out the one lobe, the calcitonin comes down within 2 days. I mean, I would have never learned that because we wrote a paper, the nadir occurs in 4 weeks. But we realized that the nadir, you don't have to wait that long. The nadir occurs in 48 to 72 hours. Okay, let me just see. Can you bring up my slide? Okay, so let me just show you. This is a patient who had surgery. Can you take out that? Okay, this is a patient with recurrent medullary cancer. It will be of interest to everybody. He had surgery in 2007. Total thyroidectomy, modified leg dissection, central compartment dissection. Now, oh, is it me? Oh, sorry. And you can see here, this was in 2007, 4.5 centimeter medullary cancer, but it was encapsulated. And there was only one positive node. Now, theoretically, if you have 4.5 centimeter medullary cancer, you would expect much worse disease and much rapid recurrence of the disease. So he did well. The rate was negative, obviously, so this was not a genetic disease. One positive node. The lateral neck, we did a lateral neck only because of the size of the primary. The decision about lateral neck will depend upon size of the primary, number one. Number two, multiple central compartment nodes. And number three, what does the imaging show? If there is something suspicious imaging, we are very generous. If there is something suspicious in the lateral neck, we'll get a needle biopsy preoperatively. Because we know there is medullary cancer and we'll be more aggressive. Okay, so this is a patient who had surgery back in 2007. Let me see what happened to him. So in 2020, nothing happened between 2007 and 2020. Now, one positive node, is it an indicator of prognosis? I have no idea. I don't know. Any thoughts, our pathologist? One positive node, is it an indicator of prognosis? Right. Okay. Okay.
Can you hear me? So I think a positive node will be an indicator of for prognosis.
So anyway, this patient did well from 2007 to 2020. Now see what happened in 2020. Can you bring up the slides? Okay. You can see here the 2020, the calcitonin is 2.5. 2021, the calcitonin goes up to 5, not very high. The CA 3. February 22, calcitonin is 48. You know this is a recurrent medullary thyroid cancer. The question is, where is the recurrence? We did the imaging studies, we didn't see anything. In November of 2022, the calcitonin is 103, the CA is high. So there is some disease somewhere. So the first investigation we do is ultrasound, the second is a CAT scan. And you, can you get me out of the, okay, great. They don't need to see me, they just need to see the pathology. You can see here. Now what is interesting in this case is the recurrent disease is pretty large. It's a bulky disease, it's about 3 centimeter disease. So what is your investigation of choice for recurrent medullary thyroid cancer? Ultrasound, CAT scan, DOTA-TET scan, or PAPI scan? Everything. Say, PET scan. Okay, fine. Okay. So some or the other, we have not been very excited about PET scan. I don't know why. I think, deep in our heart, we feel the PET scan is very helpful. At least it will tell you what is going on in the rest of the body. But I'm not sure we use it for the local recurrence, like this. Now here, you saw that there is a bulky disease. What should we do now? Let me just, go ahead, comment.
I just wanted to add a point here. We do a lot of SIRS cases, and most of the time we do pick up a lesion on ultrasound in those peculiar locations where we tend to feel this is the hidden area where we find it.
Yeah.
Behind the carotids.
Right.
We do pick up a lesion there.
Yeah.
Machines are good nowadays.
Yeah.
So I think by and large that solves the problem. We go ahead and look at the calcium and
Yeah.
they decide whether to operate.
Okay.
In reality, the ultrasound give the initial diagnosis, which can be a full stop at that point.
Okay. Can you bring that other side? Yeah, Prathamesh?
So did you do a central compartment at that time?
Yes, we did. And there was only one positive node.
So this is possibly a nodal recurrence?
Possibly what?
A nodal recurrence in the central compartment.
Yeah.
So would you not now want to look at the chest and the mediastinum?
Yes, we looked at, we do the CT scan, but I agree about the imaging studies. One of the imaging, whichever is popular in your institution, PET scan is probably the easiest way to get the scan. There was no disease anywhere else except that local disease. Huh? Yeah. I'm coming to that. Yeah, I operate. He wants me to operate, I mean, hey, don't tell the patient you'll be cured tomorrow. He's not going to be cured, you know that. Right? Okay, so.
Sir, I have a question similar to what Sir said, that in recurrent setting also, will calcitonin level decide our level of investigation, whether just a CT neck, thorax, or a PET CT?
We don't do that routinely. The only investigations we do is a good ultrasound, calcitonin and CA, which is complementary with each other. Unless there is a tremendous rise in calcitonin, we don't do any systemic imaging. Yes, Deepak? Yeah. I don't know why my image is coming up, not the real image.
If on the ultrasound you find this, but your calcitonin and CA is normal, what would you do?
If the calcitonin is normal?
Normal or low?
Okay. What would I do? Very simple. I need a needle biopsy of this. I need to find out what it is. Is it medullary cancer? Is it some other gumba? Which is my favorite term. So I don't know what it is. Is it lymphoma? Is it something else? Yes, I would definitely get a needle biopsy.
In India, we need to remember tuberculosis. People tend to forget that. Because that's very often I have found.
Yeah.
I remember at CS cervix, one time's done, nodal mass.
Yeah.
We literally wrote her off, but we did an ultrasound and it was tuberculosis. So we tend to label everything to cancer only.
Yeah. Agreed. So the needle biopsy was medullary thyroid cancer. So what should we do? Prathamesh, operate on the patient? What operation and how much of the operation?
So if it's a localized disease, you would consider doing, if you're not done the lateral neck, we would have done the lateral neck along with the central compartment.
There's nothing in the lateral neck. Would you still do the lateral neck?
Yes, I would.
Okay. Kanav?
So if there's nothing in the lateral neck, we would only address the central compartment where the disease was, but it would be a complete clearance of the compartment.
Okay. How about you?
Sir, we'll do the central neck as well as the lateral neck, sir.
Okay. So we have a little bit of debate here, and there is no consensus here. And the reason there is no consensus is we don't have any data. Now you will feel very unhappy. You do the central compartment, nice clearance. The next day the calcitonin is 100. And down the road, you find a disease in the lateral neck. You feel very guilty. Hey, I lost a golden opportunity. When the neck was open, I could have cleaned up level 2, 3, 4 without any problem. So in that regards, I don't disagree with you. But general consensus is when there is a recurrent thyroid cancer, whether it is medullary, Hurtzel cell, well differentiated, go for the target disease. Because that's the disease why we are coming to the operating room. So I don't disagree. So I did what what Kano told me. Don't do the lateral neck, you just do the central neck. And take a look here now. Okay, so the final pathology report showed metastatic medullary thyroid carcinoma. 3 lymph nodes were positive. So retrospectively, you can always say this disease might have been present since 2007. You know, patients with thyroid cancer want you to operate on you tomorrow, but deep in your heart, you know this is probably persistent disease. And there's a lot of debate in well-differentiated thyroid cancer, persistence versus recurrence. And, you know, we have some guidelines, 2 years gap, this and that, but those guidelines mean very little. Well-differentiated thyroid cancer can remain quiet for a number of years. I mean, we have seen several young kids with a lymph node that the patient says, I have it for the last 20 years. You do a needle biopsy, there is papillary thyroid cancer. So we did this. You can see here the recurrent right neck dissection. There are 4 positive nodes. The size of the largest node was 3.3 centimeters. Pretty sizable disease. Now the question comes, should I radiate this patient now or no? The risk of recurrence is almost 100%. Okay. Okay.
Adjuvant radiotherapy.
I think, you know, I mean, her comments are very appropriate. This is the patient who is at very high risk of recurrence. The why we are so reluctant about radiating thyroid cancer, because the major reason is you lose an opportunity for future surgical intervention of recurrent disease. Because there is scarring, fibrosis.
There's a lot of toxicity with radiotherapy.
Correct. Yes. The toxicity of radiotherapy is always a concern. And many times we have radiated very advanced thyroid cancers and they have ended up with esophagitis, the esophageal stenosis, and those are very difficult problems.
I think the techniques have changed
Correct.
in the past 10 years or 20 years. I don't think we see a lot of esophageal stenosis and strictures, but I think we should reserve radiation when actually it is necessary.
Correct. I think that's where I think a decision making goes between you and me and the whole team, that whether we should radiate the patient. But there is a considerable reluctance about external radiation therapy in medullary or well-differentiated thyroid cancer. So I operated on this patient. You can see here, there were 8 nodes. The largest was 3.3 centimeter. Calcitonin came down. 7, CA2, he was recovering very well. And this is the pathology. You can see here metastatic medullary thyroid cancer. You want to comment? Because I don't know anything about this. You know, most of the time I ask the pathologist, please write on it. You know, otherwise I get lost.
You know, melanomas are the big mimics anywhere.
Right.
And this is considered the melanoma of the thyroid gland. Medullary carcinoma is considered the melanoma because it has so many mimics. It can look like papillary carcinoma, follicular, it can look like wholly differentiated. Very often it looks like itself.
Yeah. Great point. Very important point. This was not melanoma. They did the Melin stain and everything. This was not melanoma. This was medullary thyroid cancer. But a good point, you know, very important point. But keep in mind, melanoma of the thyroid is one case report, you know.
No, I don't mean melanoma in the sense that it's a melanoma. I am saying that melanomas on the whole are very good mimics of everything else.
Yes, correct.
And in the thyroid, the medullary carcinoma is a great mimic.
Correct. Yes.
of everything else.
I used to call that small cell or blue cell tumors. And there is a variety of them, including Ewing's sarcoma looks like that. Under low power histopathology without immunohistochemistry, one would be very difficult
Like
to
anything under
distinguish.
the sun.
I think with the immunohistochemistry now, you can identify exactly what it is. Okay?
There was one time when at the Tata Memorial, there were a large number of anaplastic cancers of thyroid being read. This is before they recognized that they were not anaplastic cancers, they were medullary cancers of the thyroid.
Correct. You know, that's why in the days gone by, about 10 years back, whenever you read a paper on anaplastic thyroid cancer and the authors write, I have 5 patients living for 5 years, you know, the editorial comment was, re-review the slides, send the slides to Memorial or MD Anderson. You probably were not making the right diagnosis.
Or
You know.
HNCII.
Yeah. Okay. So you can see the calcitonin stain is strongly positive. Synaptophysin is positive. Let's, you know. Okay. Medullary thyroid carcinoma is considered to be high grade when it had at least one of the following criteria. I think in my talk I mentioned about Dr. Shu's presentation, mitotic index, Ki67 and tumor necrosis. Any further comments on that? Or these 3 high grade features?
At one time, we would do a bullseye appearance. You know, just look at it and say, this is high, this is low. But now we are urged to actually sit down and count the number of mitotic figures in 50 fields. And the Ki67 also we are urged to do accurately by our counting. So we become mathematicians almost.
Mm-hmm. You want to comment on tumor necrosis and thyroid cancer? There is so much going on between the two.
Well, the number of fields we look at, we do have a rough, actually we take a whole face of the tumor to scan it. And then the number of fields that we see with necrosis tells us that it's moderate, mild or severe. Mm-hmm. And we do make comments on that. I don't know if you can mathematize it, but we do mention that extensive necrosis or minimal necrosis. Okay. And when we see necrosis anyway, it becomes high grade.
Okay. Now I have a question. Can you distinguish as a pathologist between tumor necrosis per se and a needle biopsy related necrosis?
I've seen this in breast. And I can make out in breast because you see the actual needle tract. So you see the hemorrhage and you see the growing fibrosis at the side of the tract.
I see.
And you see necrosis there. You can make out this is due to the needle. But in thyroid, I can't recollect that I have made out the distinction. Most of the time, I think we get frozen sections. We don't do too many thyroid biopsies. So I haven't got the experience in thyroid, but breast, yes, definitely. We can say that this necrosis is due to the needle tract.
Nice. Very good. Nice comments. Excellent. I just wanted to say, one of the leading pathologists who made enormous contribution in thyroid was Juan Rosai. Juan Rosai was the editor of the Ackerland's book, on surgical oncology. He was at Memorial. His wife was also a pathologist. She was chief of surgical pathology in Connecticut. He died about maybe 7 or 8 years back, and it was a big loss for all of us. He was one of the nicest person. The door is always open. Somehow or the other, our pathologists are very accessible. You just walk in, they will stop whatever they are doing, and they will listen to you, they will help you, they will answer all the questions. No, really, there is something I think there is a genetic mutation there. I don't know what it is, but I'm sure one day you will find something. The surgeons have different mutation, high grade mutation. They are always opinionated. Sorry, I shouldn't talk about myself. Okay, so this is an interesting case. Can you bring it up again? Okay, 78-year-old gentleman, 2-centimeter thyroid nodule. Needle biopsy was medullary thyroid cancer. I scheduled him for surgery. I took his consent, total thyroidectomy and central compartment dissection. Now, in life you learn a lot from the patients, and I was saying patients are always correct. So this man on the day of surgery said, Dr. Shaha, what are my complications? So I described the complications, which I had already talked to him, but he forgot about it. And he said, do you really have to take out my whole thyroid? So I had to be on thyroid medication for the rest of my life. And I kept thinking, maybe he's right. Why do I need to take out the normal lobe on the other side? And I said, sir, you are probably correct. We'll follow your calcitonin. If you agree with that, I'll do a lobectomy. I did a lobectomy on this gentleman. Can you go back to the slide? Okay. As I mentioned, patient was very reluctant for total thyroidectomy, underwent thyroid lobectomy only. Calcitonin dropped from 800 within 4 days, 3 days to undetectable. So you can't beat the success of this case, And I learned from him. This was about maybe 12 years back. And he himself told me, I'm 78. Why do I need to take thyroid medication for 22 years of my life? And he was correct, He had gauged, his life is 100, at 100, who cares, right? Okay, let's go. You like to see me more than the picture here. Okay. So the calcitonin dropped. Sorry. And this was the, comments from our pathologist. This was a 1.7 centimeter well-encapsulated medullary thyroid cancer.
You have a hyper? No, anyway, it's encapsulated. It's got the vascularity which we usually expect in neuroendocrine tumors.
Okay, well.
But I would like to see a hyper view.
Can you go advanced? No, it's not.
Yeah,
okay.
It's got a spindle cell morphology.
Yeah.
And the nuclei are suggestive of neuroendocrine. In nucleoli, they don't show prominent nucleoli. They show little what they call salt and pepper appearance, which I think this matches. And this would be a neuroendocrine tumor. That means a medullary carcinoma with a spindle cell morphology.
Very good. Okay, so calcitonin is positive, chromogranin is, you want to comment on chromogranin? I don't understand much about it.
It's positive, both are positive.
Okay. If you say positive, I say positive. Because synaptophysin and chromogranin, I don't understand much. Calcitonin, I think.
It's the science of brown. They call it science of brown mud. So if it's in the right area, nucleus or cytoplasm, and it's brown, it's positive.
Okay, so let me ask you, as a pathologist, does that influence your diagnosis?
Of course.
Really? Okay.
Yes, I think immunohistochemistry has come in to stay. Though I lived in a generation where we didn't have immuno, and my younger colleagues are more fond of it than me, but I'm forced to accept that IHC is very, very useful.
Okay, but what I'm saying is, in that case, the calcitonin is strongly positive. Yes. Is chromogranin synaptophysin important?
Yes.
Okay, okay. Why?
Important. It tells you it's a neuroendocrine marker.
Yeah, but you already have calcitonin. That's why I'm asking you.
I think they complement each other.
Okay, fine. Okay. So these are all complementary with each other. Chromogranin, synaptophysin. Okay. So you can see here, this was positive. Can you go to the next slide? Ki67 is very low here, no, less than 1%.
Less than 1%, yeah.
Okay. Okay, so this is the next case. So let me just go through this in the next 5 minutes. Ill-defined mass involving the right side of the thyroid. Firm semi-fixed, no palpable nodularity on the left side, no cervical lymphadenopathy. Investigations, let's start with our surgeons. Kana?
So we would start with a basic ultrasound and a guided FNAC from the thyroid nodule. And based on that report, we would then proceed further.
Okay. Would you do the calcitonin as a routine test?
Not as a routine, sir.
No, okay, fine. When will you do calcitonin?
If on the FNAC or on the sonography there is some doubt that this may be a medullary CA, that's when we would probably do a calcitonin, sir.
Okay. Okay, so that's what we did. Can you go to the next slide? Okay. We have a radiologist. Go ahead.
Yeah, I think this is how it looks generally. Exactly, the lesion is quite isoechoic to the rest of the thyroid. It's got a very, very strong vascularity and very few areas of cystic change. So unlike a PTC, this looks more solid. That's what I was trying to say, that this is how a medullary looks. But if we don't know the history, this needs a FNAC because of its location and the appearance. So very rarely a PTC which is more solid can look like this. So we'll do the FNAC and obviously look at the rest of the neck for any such abnormal nodes, because this is a sizable lesion. So we'll carefully look for the lateral and central compartment for the nodes.
Moshin, can you comment on the location of the thyroid tumor and the concern that the surgeon has? Is the question clear? There's a lot of data coming up now about the location of the thyroid tumor, posterior location, medial location against the trachea, and anterior extrathyroidal extension. So I'm just asking the surgeon, when he sees the report or the CAT scan or the ultrasound, what is your concern?
Sir, its location near the Sir, its location near the tracheoesophageal groove, it matters to us, sir. Or its location within the thyroid substance.
Yeah. Okay, so there is thyroid substance all around.
No, there is just one image. If you were to have a transverse section, maybe we would comment about that.
Sure. If I show you all the images, then I won't challenge you. Okay. Now I like this. See, the CT scan gives me a better idea what is going on. Look at the opposite lobe. Absolutely normal, right? I don't have to even depend on the radiologist to comment on that. Okay. You can see a nicely well encapsulated lesion. This is the kind we saw. We saw about 8 or 10 patients recently in last 3-4 years. These are, I think the pathologists probably need to kind of spend time on that and redefine encapsulated thyroid tumors. Whether this is medullary, whether it is papillary, or whether it is follicular, they are all low-grade tumors. Unfortunately, this has not been described, but I think somebody has to take the lead and say, these are encapsulated lesions. And when you go in, you see them very mobile. The whole lobe comes in your hand. Very easy to do lobectomy on these patients. Let me just take a minute. How many of you have used parathyroid evaluation with one of the newer modality in your practice? Is it available here? Is it available? What do you use? Autofluorescence. So PTI, is that easily available? Okay, fine. Okay. So there is a lot of debate in the United States about the use of these, but there is a general consensus now is to start thinking about PTI and see if there is an autofluorescence. It happens. Are there fellows here? I'm going to ask a question to the fellows. Whosoever, I'm not going to point anybody. What is the risk of removal of one parathyroid in total thyroidectomy. How many times you see, you get 100 total thyroidectomies, you are done. How many times you will see one parathyroid gland in the final pathology report? How often? We published a paper about 20 years back. Derek Lim from our institution published a paper. It was 13%. Now it is 20%. Why? Why have we become bad surgeons?
Pathologists are better.
Correct. She said it right.
He's section much more.
Right. You know, at Memorial we embed the whole specimen, and there are maybe about 100 cuts made. At one time it was 16 cuts. You know, now they embed the whole specimen, and they are finding out papillary cancer 0.1 millimeter. And I get so upset, you know, because now I have to tell the patient, you have a small cancer, and the patient's whole thinking changes from nothing to cancer. But our incidence is about 20%. And that is because we are seeing more and more incidental parathyroidectomies, number one. And number two, which we have seen, we have not collected the data, intrathyroidal parathyroid. Very common. And now I realize gods do make mistakes, you know, I mean, right? I mean, why does he have to put the parathyroid inside the thyroid, you know? But they do make mistakes. They are no better than us. You know? Okay, so this is the patient who underwent surgery. You can see here, 2.5 centimeter, medullary thyroid cancer, Bethesda category 6. Do you use Bethesda system for medullary cancer?
No, I think
fine.
we just diagnosed the cancer by the features of the nucleus.
I just wanted to bring that up because this was a wrong, you know, once they write medullary cancer, they don't have to write Bethesda 6. I think they were trying to impress that this is cancer. That's why the pathologist was doing that.
But we have seen reports where they have written Bethesda category 5 and then suspicious of medullary.
Right.
So that's when we can't make out whether it's really medullary or it's polydifferentiated or anaplastic. We know it's malignant, but which malignancy may be decided only on the final histopath. That's when we use Bethesda.
Yeah, right. So what is Bethesda?
It's a place.
No, you. What is Bethesda? Okay. Why we use the term Bethesda? Why was the first conference there? Because NIH is there, National Institute of Health, and NCI, National Cancer Institute. So now this is a trivia. If you answer that, I'll buy you dinner tonight. I'm going to Dr. Pradhan's house for dinner, so easy for me to invite you. Who was the first author of the Bethesda system in America? Find it out, okay? Actually, you know, we started using Bethesda system only, 15 years back? But the British people have been using Thai classification, Thai 1 to Thai 5. They didn't go to 6. The Bethesda went to 6. You know, we always like to do something different than the rest of the world. So we decided we'll make it 6, you know. It was more appealing. But the Thai classification was very popular in UK, very popular. All the time they reported Thai classification. Actually, the MDT, multidisciplinary team, was very popular in UK way before we started using it in United States. Okay, so I think, can you go back to that slide? I just want to show you. You can see the calcitonin is 467, CA 54, metanephrines are normal. He underwent right thyroid lobectomy and isthmusectomy and central neck dissection, just to make sure, because the tumor was large, I was somewhat concerned, you know. But remember, his calcitonin was not very high. 460 calcitonin goes along with 2.5 centimeter medullary thyroid cancer. If the calcitonin was 5,000, I'll be more worried about it. So this was the medullary thyroid carcinoma oncocytic pattern. So what are the different patterns of medullary thyroid cancer? This was written oncocytic pattern. What does it mean? I have no idea.
Medullary itself has many faces. So it has the classical neuroendocrine small cell morphology. It can have a spindle cell morphology. It can have oncocytic. Then there are patterns. It can look papillary-like, follicular-like.
Yeah.
And that is why earlier I mentioned that medullary carcinoma is like the melanoma of the thyroid. It can mimic anything. And if we are not careful, it's easy to call it some conventional type of thyroid cancer. So then immuno comes into play.
Okay. So this patient underwent lobectomy. He's not on any thyroid medication. Amazing. He has done very well. And his follow-up is going to be very easy. Calcitonin once a year. Yes, sir.
So will red mutation analysis of the specimen will it guide your further plan?
Great question. I mean, there is one principle of moderating a session. When you don't know the answer, ask the panelists. No, the answer is very simple. Yes, no. I think you don't need to. One, I would not spend time on doing the rate on the specimen unless the patient has recurred and you are considering some kind of other therapy, but otherwise I would not do it. But if you have done it, it won't change anything. Yes, there was some question. Yes, sir. Yes. I think maybe she can comment. There's a difference between germline mutation and the sporadic.
DNA testing.
Yeah, go ahead.
Do a DNA germline
Yeah,
testing.
germline or somatic. That's the main thing, sir. If it is germline, you will give it to your people. Somatic is in the tissue, basically. Sporadic, how it is.
The somatic rate
Sir,
mutation
I'll
is
just
not
take-
uncommon. You see that in papillary cancer also. We use that to treat them with selpercatinib. Okay, I think the most important part of the meeting is a coffee break. Correct? Okay. So we'll break for the... Thank you. Thank you for your help. We'll come back at 4:30. Right? Okay. Go ahead. You have to make some comments.
Thank you so much, sir, for enriching our minds. It was a very informative talk. Now I invite Dr. Prathamesh Pai, sir, to please come on the stage and give token of appreciation to our... To our moderator, Dr. Shaha. Please come on the stage. Now I also would like to request Pai sir to give small token of appreciation to all of our panelists, Dr. Chinoy, Dr. Sharmila, Dr. Momin sir, Dr. Ashwini madam, Dr. Mohsin sir, Dr. Kana, Dr. Asif Momin sir, Dr. Ashwini madam, Dr. Mohsin, Thank you. Thank you, everyone.
Welcome back, everyone. Now we'll move ahead with a thought-provoking panel discussion on poorly differentiated and anaplastic thyroid cancer. To moderate this session, we are honored to welcome Dr. Prathamesh Pai, sir, consultant surgeon at Pai Clinic, affiliated with PD Hinduja Hospital and Gleneagles Hospital. He is the former professor and chief of the head and neck surgery at Tata Memorial Hospital. He is a distinguished academic and surgical leader. We warmly welcome you, sir.
We'll briefly introduce all the panelists and request each of them to please join us on stage. Dr. Sharmila Agarwal, madam, and Dr. Asif Momin, sir, we request you to rejoin us.
Dr. Archie Agrawal, ma'am, professor and head in Department of Nuclear Medicine and Molecular Imaging, ACTRAC. Madam has more than 20 years of experience in the field and is well versed with all the diagnostic scans and various radionuclide therapies. We welcome you, ma'am.
Dr. Karthik Krishnan, a dynamic medical professional of HNCII with an impressive academic record, possesses a wide array of qualifications and skills. His approach to medical complexities make him an asset to our institute. We welcome you, sir.
Dr. Ketan Ingle is our consultant in Department of Histopathology at HNCII with special interest in lymphoma and head and neck pathology. His hallmark is his ability to simplify the complex problems. We invite you on the dais.
Dr. Tasneem Bharmal is our medical and hemato-oncologist at HNCII. Her expertise include treating solid tumors and hematologic malignancies. Her primary focus is on personalized treatment strategies. We welcome you, ma'am.
Thank you, everybody. From a very indolent cancer like papillary and equally indolent medullary thyroid cancer, we are dealing with the other extreme of thyroid cancers, the poorly differentiated and the anaplastic. Now, these are some things that we will rarely see in our practice today, but the seniors amongst us have seen a lot of these in their heydays. And luckily for us, that incidence has reduced. It is less than 1 to 2% of the thyroid cancers in practice. But yet these are so vicious that we would want to understand how to deal with them to the best of our ability, because now in the last 5 years, 10 years, the therapeutics that have come about, like Dr. Shah was talking about, the medullary thyroid cancers. Likewise, in the anaplastic and in the space of poorly differentiated thyroid cancers, we are seeing a lot of change in how we can help the patients, if not live longer, have a better quality of life. So towards that, what we would like to endeavor today is to understand how do you suspect and diagnose one of these poorly differentiated or anaplastic cancers. How do you go about it in terms of pathology? What are the various methods by which we can expedite their treatment, diagnosis and treatment? And then how do you plan their further treatments ahead in terms of how you practice it, in terms of how do you counsel the patients and their relatives towards this patient's lifestyle ahead? And then if the patient's a survivor, how do you follow them up? So this is what we propose to do in the next 1 hour. So when do we suspect a high-grade tumor? So to my panelists, we often see these patients with large swellings. Case in point, a 54-year-old with an 8-centimeter thyroid nodule, which is hard, mobile, but non-tender. Patient has had a change in voice for the past 4 weeks, still doesn't have dysphagia or dyspnea. So now this would also mimic a multinodular goiter. So when would you suspect? And the audiences, we need to give them very focused take-home messages. When would you really suspect that this is not your garden variety thyroid cancer and that this is something that we have to deal with it more cautiously.
Okay, so first of all, more the elder patient, more likely it's to be anaplastic or poorly differentiated. So that one thing I'll keep in mind. Second is the history or duration of the swelling. So if a patient says that he or she has noticed it within the few weeks and it has rapidly grown in size, rapidly grown in size, then I would keep it in mind. Then any sign or symptom of involvement of the local structures. So as in this case, change in voice, it might be because of recurrent laryngeal nerve involvement, or it can be because of dysphagia because of esophageal involvement, or dyspnea because of your laryngotracheal involvement. So all these signs during my clinical history and examination would try to take me towards like I might be dealing with a poorly differentiated anaplastic, and I might ask for an investigation in that way. So if I'm suspecting it to be anaplastic or poorly differentiated, I might directly go for a core biopsy instead of an FNAC.
Dr. Momin, you see these patients come to you referred for ultrasound. When would you actually, call the physician and tell them, hey, this is not a good disease?
I think there are a couple of things. In this particular image, what you've shown, I think we'll be immediately jumping to the one more thing is the carotid, which is encircled by lesion, one. Secondly, the way it is adherent and looking invasive in certain areas. So even on ultrasound, we use the same guidelines.
Let's not see the CT scan.
So
because the patient would be referred to you at the stage where a patient has been seen by a clinician, thyroid swelling, and now comes to you.
So I think most important is how that lesion is kind of infiltrating in the adjacent areas. It could be going to a tracheoesophageal groove. Sometimes we do see tracheal invasion itself on ultrasound because we tend to see the vascularity, which is kind of bridging vascularity between the trachea and the lesion. So that is one. And when we actually see a lesion which is very hard and showing a lot of vascularity, lobulations, and it tends to encircle the carotid sheath in certain way, at least 180 degrees or 90 degrees. And last but not the least, if it is going posteriorly into the tracheoesophageal groove. So if these signs are there, we know this is not the run-of-the-mill so-called MNT or multinodular thyroid, and then we'll immediately kind of get alarmed. Then at the same time, we try and see two more things. One is the jugular, if there's any thrombus in that, and last, if there are any large central compartment nodes. So I think that's how we would try and analyze. Moment all these signs are there, I think we would suspect that it is a higher grade lesion, not necessarily particular type, but we would feel that this is a higher grade.
So I think these are very important points that we need to remember. Dr. Shah also pointed out to a lesion and he said, what is it that makes this more vicious? So more posterior the lesion, the one that goes in between the trachea and the esophagus, that effaces the fat pad there. That's the one that is really going to trouble us. It's coming into close proximity to the trachea. It's going to come onto the muscularis of the esophagus. It goes into the nerve. It might enter the cricothyroid joint area. So these are the points we need to look out for. So our radiologist is key. So you need to have a good dialogue with your radiologist. If you find something sinister, then you need to document it before you send it, whilst you send it to the radiologist. The radiologist should know what clinically you're worried about, because then they can actually look for it on the scans. And that's where, I had sent a few months ago to Dr. Momin, a patient who had been operated outside and come back with a residual thyroid. And then he told me that this patient has an infiltration of the tracheal rings on an ultrasound. So I didn't even have to do a CT scan. So the moment he said that, I knew that I was dealing with something which was bad, and truly that was a tall cell variant thyroid cancer. So these are things that we need to look out for and apply it. Because in poorly differentiated and anaplastic, your suspicion is what actually will help the patient. The moment you have something which rings a bell that this may be something different, you will proceed in a different manner. So remember and look at this slide and understand that your cell of origin, excuse me, you're disturbing us. The cell of origin is a follicular cell. And that cell can be transformed in various ways through various mutations which we are now understanding, which we can actually target. So we have to now get over this just a morphologic picture, but understand what is the genetics behind it, so that we understand which of these pathways we can actually target. So when you look at the papillary and follicular, we know that they have certain mutations. But moment they go into a poorly differentiated and anaplastic, that whole scenario changes and you have a whole load of mutations that come up. And it is very important today in precision oncology to understand that it's not just the RET or the BRAF. There may be various other pathways you may target and help your patient. So it is not a papillary CA thyroid, but it is a RAS mutation of a cell which has caused a tumor. So we are going to move away from an organ specific to maybe a cellular specific oncology. So this is something that you need to keep in mind. So we will do a true cut biopsy. Madam, if you get a true cut biopsy, Dr. Chenoy, Ketan is here, sorry. How would you proceed with this? Now, Dr. Karthik has told you that this is not a good cancer, and that Dr. Momin has been requested to do a true cut. How does that change your management?
Yeah, first I'll address about whether FNAC
I
or
couldn't
true
recognize
cut.
you.
Yeah. So we most often for thyroid specimen we tend to receive FNAC first. So a diagnosis of anaplastic carcinoma can be quite confidently made on the FNAC itself. But nowadays, as we are going towards the molecular pathology, it is suggested that if you are suspecting an aggressive variant of thyroid carcinoma, it's better to obtain a true cut biopsy. And in many cases, as it's already extrathyroidal or already aggressive, so we ask for the true cut biopsy. So otherwise, FNAC features of an anaplastic carcinoma are quite characteristics. You have, as sir mentioned, bizarre. When you are seeing, a myriad of bizarre cells, then we suspect anaplastic carcinoma and with a characteristic neutrophilic infiltration that we often see associated with anaplastic carcinoma. And about the poorly differentiated thyroid carcinoma, you need to see mitosis as well as necrosis on the FNAC, and which by definition shouldn't have well-formed papillae or papillary nuclear features or the microfollicles, which are indicative of a follicular lesion of the thyroid. So from that, then we move on to the further molecular diagnosis.
Would you do next generation or advise a next generation sequencing at that point?
On the FNAC sample, it's difficult. Sometimes the material is less. We can go for cell block and do a BRAF IHC. Means in the cases of anaplastic thyroid carcinoma, we are supposed to obtain BRAF mutation status, BRAF V600E, which can either be performed by BRAF IHCs, either on the cell block or in the true cut biopsy, or we can do it by the sequencing, the molecular pathology, wherein we can use either PCR or next generation sequencing for that. This is important.
This is very important, as even Dr. Chennai was mentioning, that the pathology is moving towards more of IHCs, because then you help understand the biology of the tumor better. So keep these in mind, that you need to have IHC markers being used in a bigger way in your practice, and all these will tell you about what are the possible differentiators between each of these tumors, and it helps you understand poorly differentiated from anaplastic. Of course, next generation sequencing, yes.
Shall I add on the IHC, sir? So in the poorly differentiated carcinomas, we often have a medullary carcinoma as a differential. They might have morphological overlaps. So this is a very important differential that we need to rule out. And to diagnose on the core biopsies and in the on diagnosis of poorly differentiated anaplastic can be helped by the use of IHCs. So
what is the new, pathologies that are being, defined in the 5th protocol of the WHO?
Yeah.
classifications?
So classically, we all had differentiated thyroid carcinomas, which were for either a follicular carcinoma and a papillary carcinoma with all its variant. And we had on the other end of the spectrum, the poorly differentiated thyroid carcinomas and the anaplastic carcinomas. Now, when they studied bad behaving, well differentiated or differentiated carcinomas, like follicular and papillary, which are bad behaving. So when they studied them in detail, now they found that the indicators of the bad behavior were the presence of mitosis, increased mitosis, as well as necrosis. So when you have a differentiated thyroid neoplasm, but with increase in mitosis and the necrotic features, then those are now being called as high-grade follicular cell-derived non-anaplastic. So non-anaplastic indicates that it is not anaplastic carcinoma, but they are still differentiated. And they are not the usual ones, but they are high-grade. So that's why whenever you see routine papillary carcinoma or a follicular carcinoma with increased mitosis or necrosis, we are supposed to call that a high-grade follicular cell-derived non-anaplastic carcinoma. And the poorly differentiated carcinoma comes as a subtype of this.
So how do you differentiate that clinically? Does it make a difference to us that it is a high-grade non-anaplastic versus an anaplastic? Or do they behave the same, the high-grade? Why was there a need to make this differentiation?
Because the category of the differentiated neoplasms, follicular and papillary, some of them, despite being differentiated, were behaving worse than the usual. That's why this category of an intermediate prognostic value was carved out, and that's why it is called as the high-grade differentiated non-anaplastic.
Dr. Shah, can you just tell us more about this, if it's possible?
Well, this differentiation is very critical because now we have got new therapies for anaplastic thyroid cancer, which we didn't have before. The whole anaplastic thyroid cancer now is molecular based. And we like to divide it into BRAF positive or BRAF negative. Just like the oropharynx, HPV positive, HPV negative. The BRAF positive tumors do remarkably well. They did not do well in the past because we didn't have the drugs. Now we have that, and it's very critical to differentiate between poorly differentiated and anaplastic. The problem is, around the world, it is kind of mingled together.
Right.
And that's why whenever somebody says, I got 10 patients with anaplastic doing well, you say there is something wrong. They were probably not anaplastic thyroid cancers. I just want to bring up one point about the true cut biopsy. In the past, we used to do a lot of true cut biopsies for anaplastic thyroid cancer. I used to do them in the office. Now, we rarely do true cut. The only time we would do it is strong suspicion of lymphoma, that the pathologist says, I need more material for all the studies. But now we can do a core biopsy. Let's divide it.
Yeah.
Fine
True
needle
cut.
versus core rather than true cut. True cut is very rarely done now.
Okay.
And if you're going to do true cut, be careful. The bleeding is a major concern. And don't do true cut biopsy without looking at the CT scan to know where the anterior jugular is, where the carotid is. But if you really want a core biopsy, like for histopathology, do a ultrasound guided number 18 needle biopsy. That will give you enough specimen to look under the microscope and get a good analysis. So
that's a good point. Yeah.
Yeah. We don't do true cut. I used to do them in the earlier years.
So we would get everything ultrasound guided. So Dr. Momin, any comments?
There are only a couple of cases where we upgrade from FNEC to biopsy, and one of them is any lesion which looks like either infiltrative lymphoma or anaplastic radiologically. When we start looking like that, then we do 18 or 16 gauge biopsy looking at mainly the vascularity, and then we take multiple cores for this thing. And we also add one or two things, is the imprints we add, so they make a little bit of cytological evaluation.
Right.
And rarely we do FNAC plus biopsy together. So I think Dr. China also sometimes tends to tell me that she would like to have 1 or 2 slides for additional analysis.
So from the primary, and if there's a node from that as well?
No, not the node. If we choose to rely on the primary tumor, then we do only from there. But we add 1 or 2 slides for their, use.
Sure. Yeah, Karthik.
Coming to the differentiation of this high-grade follicular derived to poorly differentiated and the other one. So if you see the original definition of poorly differentiated by the Turin criteria, there the one key aspect is absence of these papillary nuclear features. But MSKCC, they have got a paper, sir, in which they showed that even with this presence of papillary nuclear features, few of these high-grade tumors behaved very badly. That's why their criteria is different from the Turin one. And because of their staging, now WHO has come into division of this high grade into 2. One is poorly differentiated with this characteristic, these 3 criteria of Turin. And the other one is a high grade follicular derived, which is not poorly differentiated, but though it behaves like a poorly differentiated or anaplastic. So,
You want to add anything?
Yeah, the same thing. So now, as you are projected out here, so the original MSKCC criteria about the poorly differentiated has now been incorporated in the high-grade non-anaplastic thyroid cancer.
So now that we have established that this is a bizarre tumor, it is possibly looking high-grade, how would you then investigate this patient? This patient has got a hard mass. You got a diagnosis suggesting that it's a high-grade tumor. Would you just do a cross-sectional imaging, or would you do anything more?
So if I'm suspecting it to be poorly differentiated anaplastic, my first investigation would be a PET scan. I would want to rule out distant mets because we know that more than 60 to 70% of these patients will present with distant mets now or in the future. So before I go into any radical or any treatment, I would want to rule that out. So once the PET scan is done and if it's not showing any distant mets, next would be the local evaluation of what structures the disease is involving and whether if I'm considering surgery, what would be my extent of surgery be? Would it be a morbid surgery or a...
We'll come to that. Archie, does a PET scan help you or do you need anything else?
No,
What is this FAPI scan that we are hearing? FAPI?
So whenever we are dealing with a poorly differentiated or anaplastic, FDG helps because FDG shows a lot of avidity with poorly or anaplastic. FAPI comes into play only when you're planning a treatment because it has a surrogate for treatment. So if you do a gallium FAPI, you can treat with lutetium FAPI. So that comes later. For investigation part, FDG PET-CT suffices because you see the primary per se and also if there are distant metastases, whether it is lung or bones or liver, everything.
So is this a routine in all thyroids or only in particular cases?
Only in poorly differentiated anaplastic. If you look at differentiated CA thyroid, FDG PET-CT has no role. Only when it is, like maybe sometimes in Hertel cell people do. So otherwise in a purely differentiated, there's no role of FDG PET-CT.
Would I be able to, on a PET scan, understand whether this is a poorly differentiated thyroid?
If
someone has sent a thyroid for a PET scan, and they pick up a FDG activity, does it mean that it is poorly differentiated?
More FDG activity or more SUV value will tell you that it is a more de-differentiated tumor. It will not clearly tell you that it is poorly differentiated.
Why is that?
That is because as it is going towards de-differentiation, the FDG activity is higher. So that's the reason why you'll have increased SUV values. And for a differentiated tumor, the FDG activity is very low. So, you can say if your SUV is above 5, about 10, you know that you are dealing with a more de-differentiated tumor, which could be poorly differentiated or an anaplastic tumor.
So it is something to do with the sodium?
Sodium iodide importer, that's like completely different. Sodium iodide importer, when you know that in a differentiated CA thyroid, it's going to concentrate radioactive iodine, so you have your sodium iodide importers which are fine. But FDG and sodium iodide importer are completely different. When we say in differentiated CA thyroid, we say the flip-flop. When your iodine is positive, they say FDG will not. And when your iodine is negative, the FDG will be positive. But it is not a true black and white picture. Ke ye positive to wo negative ho to ye. Right. You have a gray zone. You can have a radioiodine avid disease, which is also avid on FDG. but you know that these patients are not going to do that well. So that picture it gives you, but purely to say that, based on the FDG, to say that this is going to be a poorly differentiated or anaplastic is going to be difficult.
So this is the only indication today in a thyroid cancer that you would do a FDG PET. So if you have a report which suggests that you have a bad disease, then you would want to consider doing an FDG PET. It gives you, today what we do is a FDG with a CECT. So you get not only a CT, cross-sectional imaging, you also get the morphology and as well as the uptake. And it also helps you diagnose any distant metastasis. So Karthik, is there a different TNM for this kind of staging, or is it the same in all thyroids?
No, so for anaplastic it is different, sir, as compared to your other differentiated. Maybe the T stage is same.
T stage is the same.
T stage is same, but the final stage is different. So all anaplastics are considered as stage 4. You have got A, B, and C. A is when it's only in intrathyroidal. B is when it has spread to the local structures or the neck nodes, and C when it's distant metastasis. But the T stage remains the same.
Right. So we have to focus on this T4, T3 and T4A. T3 is when it's 4 centimeters and more, and T4A is when it goes beyond the thyroid capsule. So just like in a medullary, if you've got a tumor which is outside the thyroid gland, you're dealing with a very vicious disease if it's either poorly differentiated or anaplastic. So this is what you need to focus on in your cross-sectional imaging in order to understand whether your disease is localized and treatable or it has gone beyond. So if you have a diagnosis of a poorly differentiated thyroid cancer, what would be your management protocol? Would it differ from a differentiated thyroid cancer?
Yes, sir, it would differ. So first of all, I would see the general condition of the patient. Whether he can tolerate the most radical treatment, or if it's a poor general condition, then he may not be able to complete the whole treatment. So then I would see the local disease extent, what my surgery would entail, whether it will be a simple total thyroidectomy without any morbidity to the patient, or if I need to remove any critical structures. And even counseling of the patient and talking to the patient and caregivers.
Only poorly differentiated. We are not talking of anaplastic.
Yes, I'm talking of poorly differentiated also, because we know that they also behave bad. And over a subsequent period, even many of them, more than 60 to 70%, can come back with distant metastasis. So we have to talk to the patient. We have to explain them that the overall histology of the disease is bad and what they are expecting out of the treatment. Whether he or she wants to remain without any morbidity of the disease as per, or they don't want any morbidity from the surgery.
So what surgery would you do for them?
So if it is intrathyroidal disease, it will be a total.
If it's a 2 centimeter nodule, 4 centimeter nodule, would your surgery change?
No, so it would remain, if none of the critical structures are involved, it would be a total thyroidectomy with a ipsilateral central compartment clearance.
Dr. Shah, would you differ in that? If it's diagnosed as a poorly differentiated thyroid cancer, would you do something less?
Yeah, I think, the most critical aspect of advanced thyroid cancer, whether it is poorly differentiated or anaplastic, is the surgeon's first judgment. Can I take this out satisfactorily? If it is involving only one lobe, which is not uncommon, and the other lobe is normal, I'm not in a rush to take out the whole thyroid. Because the radioactive iodine, the whole idea of taking out the whole, total, or doing a total thyroidectomy is to facilitate giving radioactive iodine. The radioactive iodine does not work here. So there is no need to be too aggressive. At the same time, you got to make a clinical decision. Can I take this out with satisfaction?
Right.
If you think you cannot, then go for ancillary treatments. If you think you can, even in olden days, anaplastic, we would operate on them. Today, we rarely operate on anaplastic as a de novo because we have got powerful drugs, unless it is BRAF negative.
BRAF negative. So that's a point that we need to, yeah, Rachi?
mean, are you coming to radioactive iodine treatment in poorly differentiated?
We are coming, yeah.
I just want to make one point about the PET scan. The SUV that you use, we don't use that very often as a decision maker. The highest SUV we have seen is in Hurthle cell tumors, even benign Hurthle cell tumors. So we don't use that as a major decision maker. We do it to get an idea if there is a disease that I cannot identify in the abdomen, liver, kidney. I think that's where it helps, or bones.
I agree completely with you, sir, because that's correct. But thyroiditis is different, like, you know, you have diffuse uptake, this, that. Here we are dealing with cancer, so point well taken, sir, that's correct what you're saying.
So my point of debate here was that all guidelines mention that we need to do a total thyroidectomy and central compartment in a poorly differentiated thyroid cancer. And we hear this often in all thyroid meetings that we need to do less. But in general practice, everybody follows the NCCN guideline, and NCCN guideline mentions total thyroidectomy for all poorly differentiated.
I just want to make a comment about guidelines. You know, I mean, I was involved in both the anaplastic guidelines. The guidelines is a committee decision. It's like politics. You sit down, you want to sell something in the guideline, put the point at 4 o'clock in the afternoon in Chicago airport. Everybody's in a rush to go home. You know, they don't want to miss the flight. Everything is accepted. And the classical example, I make this criticism very openly. In 2006 guidelines, they came out with a statement, I'm talking about well-differentiated thyroid cancer, with a statement, central compartment, prophylactic central compartment dissection may be considered.
May be considered, yeah.
Right? This was in 2006. Everybody went on the bandwagon of doing central compartment dissection, and the smart surgeons immediately realized that I'm hurting patients and not helping them. So in 3 years, the guidelines changed.
Yeah.
I mean, how can you accept the guidelines being changed in 3 years? The current time that it takes for the guidelines to come out is 2 years. We were involved in anaplastic thyroid cancer. Both the time it took 3 years. Every other week conference call for 2 hours. I mean, it's too much work for the, and remember, this is voluntary work.
Voluntary work, yeah. So, what should we do?
Again, I'm going to go back to what I said. I would not do, it is not a carte blanche treatment. That's why I made a comment that if the opposite lobe is normal, even in anaplastic, I wouldn't take it out because you're going to hurt the patient more. If the nerves are gone or the parathyroids are gone, the patient is going to suffer more. We never put that in the equation. Now, looking at the CAT scan, knowing that the RAI is not going to help, why take it out? Just take out the disease.
So now that brings us to the moot point, adjuvant therapy. We discussed that if we are not going to give radioiodine to this patient, there's no point in doing a total thyroid, which I agree. So if you have a diagnosis of poorly differentiated thyroid cancer, do you have a need for adjuvant therapy? And if so, what would you do? Archie.
So I beg to differ because there are a few there are a few papers which say that even in the poorly differentiated CA thyroid, 30 to 50% of the cancers may have some differentiated component, and that is the reason why they may concentrate radioactive iodine, and it has a genuine benefit if you do a radioactive iodine scan, see the uptake and treat the patient, and there are studies which have shown overall survival benefit also. So for all poorly differentiated, I would suggest that the patient should undergo a total, because I don't think there are other therapies which are going to help. And if it is radioactive iodine avid, it's definitely going to help. So patients should undergo a total thyroidectomy, and then if avid, we should treat with radioactive iodine.
So Dr. Shah, we read so many of your papers talking about the continuum.
Yes.
So we know that it is not just one papillary.
It's a continuum of disease.
It's a continuum of disease in the entire gland.
And, in that way, I think one would say, okay, even in Hurthle cell, we use radioactive iodine, knowing very well that the Hurthle cell tumors don't respond to radioactive iodine. Why do we use it? Because 10% of the patients may have some benefit. Remember that word, may. And I think the data is very iffy to kind of just say, okay. Now, the point that he's bringing up is, If technically it is difficult to do total thyroidectomy, why invest our energy in taking out the other lobe where the radioactive iodine is unlikely to be very helpful? I'm using words very carefully. Yes, I don't disagree with you 100%. If you have done a total thyroidectomy, I don't think there is anything wrong in giving radioactive iodine. Because nowadays you can do with thyrogen very easy. Once and for all, it settles the issue. You know, sometimes when it comes to cancer treatment, you want to settle down, you know, and that's why you use it.
So,
Just to add here, in our country, Dr. Baal is there in Delhi. I want Madam's take on it. So he suggests that we can do a hemithyroidectomy and then he will ablate by radioiodine the other lobe. So what is ma'am's take on it?
See, he has taken differentiated CA thyroid, low risk patients, जिसमें hemi भी काफी है. You don't have to go in for radioactive iodine. So everything has changed. He did it before 2015 के patients and everything. So I think, I mean, the patients that he chose were all low risk patients. There's no need to ablate with radioactive iodine. Why do you want to waste radioactive iodine just giving for 2 cycles, 3 cycles, 4 cycles, and then you talk about radioactive iodine can cause leukemia, lymphoma, this, that, second malignancies, all those things. Why do you want to give radioactive iodine when it's not needed and not required?
So now, if we are not giving radioiodine, or if it doesn't pick up, Madam, do we give external beam radiation?
So for poorly differentiated, again after surgery, depending on what are the histopathological features, in case it is a positive margin, in case there is an extrathyroidal extension, or in case there is a lymph node metastasis, for poorly differentiated malignancies, we offer adjuvant external beam radiotherapy with intensity modulated radiation technique.
So if we have to give radiation, how soon do you have to give radiation? Is it the 6-week rule mandatory even in thyroid?
I'm not sure of that number, but usually within 3 months, I think we consider for adjuvant treatment.
So any comments?
The 6 weeks was the golden rule that Memorial popularized when Bhadrasen Vikram was with us. I think that has been challenged many times. We go as, let's say you have done surgery and there is a complication. You're not going to give radiation right away, you're going to wait. So it's a matter of disease versus treatment. And is it appropriate to wait for 6 months? No. Should we do it in 6 weeks? Because that's a standard that we developed. Can we do it at 3 months? Absolutely, yes. I just want to bring up one point about ablating the opposite lobe. You know, Greg Randolph from Boston wrote a paper that you can ablate the opposite lobe. The bottom line is, does the patient need that ablation?
Right.
I think you brought it up very well, you know, that in the low-risk patient, it is not necessary. When do we consider, if you really feel very strongly the patient needs radioactive iodine, but you can't do it for medical reason, cardiac reason, or one vocal cord is paralyzed and the patient does not accept the risk, 1% risk of tracheostomy, then very well, you know, ablate with 75 millicurie. It takes about 6 months. It takes a long time. And what we don't know is it as effective as surgical thyroidectomy? I don't know that.
So it's very difficult to ablate the normal thyroid. It's very difficult to ablate. It's not very easy. It doesn't go up with one dose.
So the point I raised these two issues was the temporal relation and whether we need to give radiation therapy. So if you need to give radiation therapy quickly, within, let's say 3 months, then you would want to see that the patient is not off thyroid for long. Patient needs to get the scan done earlier to see efficacy of radioiodine, and possibly thyrogen should be considered. Do you use thyrogen routinely?
For all patients who would like, you know, whom we want to, for intermediate risk, where you want to treat with less than 100 millicuries, we are routinely, I mean, if the patient is affordable. In India, that affordability is an issue.
What is
so
the cost?
90,000 rupees
And
from our pharmacy.
what's your protocol
90,000, okay. So first, 2 injections, 0.9 milligrams, 24 hours apart. So 1 injection, 1 day, 24 hours later we give the second injection. You know, because we are used to giving a diagnostic, seeing the scan also. So that's why on the second day, after giving the second, see, you can just
How soon after surgery can I do this?
immediately, as soon as the inflammation subsides, 7 days or something, we can aram se do Thyrogen. So, normally when we are doing Thyrogen, you can directly give the therapeutic dose, but because we are used to doing a diagnostic, that's not the ideal protocol. So what we do is give the first dose, second day we are giving the second dose of Thyrogen. 3 to 4 hours later, we'll give a diagnostic dose, 2 millicuries. Next day, that is the third day, we'll do the scan, and the same day we'll give the therapy. And on the fifth day, we'll measure the TG. So that's the protocol.
Great. So, yes, sir.
Can I just bring up one point about diagnostic radioactive iodine? We used to do that very routinely. Now we do it only in selected cases, like the patients with distant disease, proven distant disease, because you really want to get a right dose. But otherwise, for the intermediate risk, where we use radioactive iodine, we just throw a number.
Yeah.
Whosoever says 75, okay, everybody goes by 75. Somebody says 100, they go by 100.
empirical.
I used to attend their meetings and I used to throw the dias. And they accepted me. I said, I'm stupid, I don't know anything about it.
But they don't use a specs. But no, you can even use dosimetry calculations, but they don't use that
What did
for
you say?
calculating the dose.
That is dosimetry, but that's not done. We normally give the empirical only based on lymph node positivity, how many
And
numbers,
Dr.
what is
Shaha.
the size.
Directly jumping to therapy only, not doing any
So one more point regarding doing the diagnostic scan, because more and more of tall cell positivity we are seeing, and when it's tall cell positive, it doesn't show uptake. So, then giving radioactive iodine is just a waste. So I think it has a point in doing a diagnostic study.
Yeah, there's a lot of things that are changing in radioactive iodine. You have to realize one thing. The majority of the thyroidologists, I'm not going to distinguish surgeons between endocrinologists, are going away and away from radioactive iodine because it has not shown beneficial effect to prolong the life or better control.
That's because they want to propagate lenvatinib, and that's the reason why they're saying radioactive iodine is not useful. It's actually useful.
So the new guidelines published just last week do mention that even low to intermediate doesn't require radioiodine. Earlier it was low, now it is low and intermediate.
Intermediate, yes.
So we are moving towards only the high
Because,
risk.
lenvatinib, you'll have to give all these TKIs, lenvatinib, that's the reason why.
No, if you don't fail, then you don't need it. Okay, so this is a very nice paper that way back in 2019, but it actually looks at all the clinical characteristics of a poorly differentiated in comparison to thyroid and an anaplastic thyroid. It's a very beautiful paper that actually looks from MSKCC, which looks at all the cell of origin, the diagnostic criteria, the clinical pathological features, and you can see in one comparison what is going to affect your patient. So look at the poorly differentiated clinical pathological characteristic. Median age 59. 69% of patients presenting with extrathyroidal extension. 50 to 85% of patients develop metastasis in the neck, and 85% develop distant metastasis. Now look at the anaplastic. More than 90% present locoregional invasion, and 20 to 50% of them present with distant metastasis. Now, the predictors of survival. Look at the DTC is looking at 55, and it's poorly differentiated, it's 45, and in anaplastic, older your patient, worse is the prognosis. And management seems to be, as we go towards poorly differentiated anaplastic, you need to be more aggressive, right from your primary site to the neck dissections. And outcomes. Look at the outcomes. The 5-year survival in a poorly differentiated, 66%. And an anaplastic, median survival is 1 year in less than 20% of your patients. So on an average, your patient is going to live for 5 months in comparison to a differentiated thyroid cancer where it's more than 90% survival at the end of 20 years. So this is something which is very striking, and it needs to actually percolate in your brain, because this is how you're going to learn to manage anaplastic thyroid cancer. So less than 2% today of your patients will be anaplastic. 10% of them will actually have only an intrathyroidal tumor. And these are the ones that we need to go after. We need to be more aggressive. 80% present with local invasion, mostly in the trachea, then followed by esophagus, and then the surrounding structures like the carotid. 40% will have distant metastasis, mostly to the lung, and that is why we need to have the PET scan and other imaging of the distant sites. So now, Karthik mentioned about the TNM being same, but the staging differs. So all anaplastic carcinomas are considered T4 tumors, and stage 4A, 4B, and 4C, depending on whether they are localized, whether to the thyroid, whether they spread outside the thyroid, or they have a distant metastasis. So this is what makes anaplastic thyroid cancers different from your poorly differentiated. So this is a paper from MD Anderson published last year, which talked about their method of managing a patient who has anaplastic thyroid cancer, which has spread outside the thyroid. So we know that for a tumor within the thyroid, you will go after it, do a total thyroidectomy, and then follow up with some further treatment. Karthik, how does your initial workup of an anaplastic thyroid cancer differ from a poorly differentiated?
So coming first to pathology, I would, if I am suspecting anaplastic and if my pathologist also tells me that it can be anaplastic, I would recommend them doing a BRAF at the same time. So before surgery only, if in that biopsy specimen, if they are able to tell, I would want them to do. And that's one thing. BRAF is one, because we know there are treatment options available.
So Ketan, is it available with us? In the country, can we do this BRAF on
Yeah,
IHC?
we have BRAF IHCs available, sir. So BRAF IHC V600 is specific mutation IHC.
So it's commonly available and it can be done.
It's available in most of the major cities. It can be done on the either on the cell block or on the tissue biopsy specimen.
So only thing that differs from your poorly differentiated is possibly to do, be after your pathologist to get this done, so that we know how to manage this in future. So looking at a thyroid, anaplastic thyroid, yeah, Nilesh.
One very common clinical problem we see in other cities where the pathologist may not have seen so much of volume. They would give report of FNAC as poorly differentiated slash anaplastic. In those cases, how should we go for directly for surgery if it is clearly operable, or should we go for core biopsy or some more investigations that we have discussed?
So if it is clearly operable and if you are suspecting, if they have given a report of poorly or anaplastic, you should directly operate, because any time frame...
You're saying before surgery, what would you do if you got this diagnosis?
Yes, sir. So that's what I'm saying. We should not go for further investigation, because...
You won't do a PET scan and...
No, I will work up the patient. So PET scan and all I have done, I have ruled out distant metastasis, and as he said, it's only intrathyroidal. I would go for surgery upfront and not repeat the biopsy again, because any time frame we delay, we know that these tumors tend to grow very rapidly, and we might then have... Our surgery won't remain the same if we lose out a week or 2 weeks also. So we would operate, and on the final histopathology, we'll get the final whatever the diagnosis is.
Dr. Shah, do you agree?
I agree about that. I think he said it very well. I just want to bring up one point, if I may, because we have been talking in every thyroid conference, we talk about positive margins. Positive margin in thyroid is a state of mind. Because if you realistically look at it, the thyroid is 4 centimeters by 3 centimeters by 1 centimeter. You've got 2 centimeter tumor, it has to be out of the thyroid. You send the specimen to the pathologist, the first thing they do is ink it, right? They're inking the whole tumor. So positive margin means very little to make a decision about treatment policy. What is more critical in that case is to ask the surgeon, did he take it out completely? Was he happy at the end of the operation? So to me, positive margin, the only time I would be concerned about positive margin is you've done a lobectomy. and the isthmus margin is completely positive, then I would be of some concern. That's why whenever we do a lobectomy, we mark with a silk the isthmus so that the pathologist can spend more time to look at the isthmus. So I think I just need to bring up the issue about what is positive margin in thyroid.
Mostly R plus disease which is left behind.
Right. That's
Right.
very important.
Any questions from the audience? Okay. So we are looking at a lesion which is intrathyroidal, and you said that you will do a total thyroidectomy. Now, NCCN guidelines, again, I bring these guidelines up, they talk about resectable and unresectable or borderline resectable. And then when we look at what is the treatment, both seem to be looking at neoadjuvant therapy. So Tasneem, would you explain to us why would you still consider a neoadjuvant therapy in a patient who is clearly operable? Stage 4A intrathyroidal disease, why are we still going to consider neoadjuvant therapy?
So if it is increasing a chance of
What is the goal of our treatment?
increasing the chances of R0 resection, then we would consider. But we have to understand that these drugs are not easy. So I mean, that is something that should be considered. You cannot just send a patient for neoadjuvant and say that it has to be given. If the patient is borderline resectable, or not a candidate for any of these targeted agents, then surgery should be considered. Clearly, unresectable patients is a different story on the whole. But these borderline cases, we should look at it. Neoadjuvant is an option for BRAF V600E. What about the non-BRAF? So that is another challenge. And for us in India, another challenge is that these drugs are not accessible. So even if I have to get the original molecule, it is exorbitantly expensive, somewhere around 50 lakh a month. This is how much it costs. If we get some molecules from Bangladesh where it is produced, that is one avenue to explore, but the patient should be willing because we don't know how the quality of those drugs are. So there are a lot of challenges. It's not as simple in our setting, at least at this point of time.
So why do you use neoadjuvant therapy?
Yeah, if you read these guidelines, take a look at it. Stage 4A and B, okay? Resectable in parenthesis, potentially curable with surgery.
Yeah.
Then it is written, neoadjuvant dabrafenib, trametinib for BRAF mutated disease may be considered. Very, these are politicians. They are not committee members. You can see that how they are kind of, going on both sides. Would we use
do you all use it?
neoadjuvant? Yes. If it is BRAF positive anaplastic thyroid cancer, we would use it because we know from our track record, truly intrathyroidal small anaplastic is rarity. And we have seen that even in that group of patients, the local recurrence is very high.
Right.
So if you have a drug that is available, and one of the things we do is we do the IHC within 24 hours. I think our pathologists are very good. Even if the patient had a biopsy outside, we'll repeat the biopsy because it is much faster. I can do it in my hospital than trying to get the slides from New Jersey, which takes forever. So yes, if it is positive, we would treat. That's why I made a comment in the beginning. The anaplastic thyroid cancer is two groups, BRAF positive, BRAF negative.
How soon can you tell us BRAF?
Sir, for the IHCs, it's like 24 to 48 hours depending upon this thing. But for PCR and NGS-based method, they take longer.
No, so we would do IHC with BRAF. So in 24 hours, we'll get an information.
Yes, it should be in an ideal setting.
24 to 48 hours, but you have to make sure you communicate with them, tell them. So you have to kind of, whatever you call, tell them, beg to them, please do it. One of the things we do at Memorial is, and the same thing, that's why the MD Anderson used the word fast.
Fast.
Where the minute we know there is a patient coming in with anaplastic thyroid cancer, there must be about 100 emails. And there is no appointment. It will be done. There is no scheduling. Patient will be seen tomorrow or today. There is absolutely no, even if it is 6 o'clock in the evening, we'll see the patient.
Right.
And the surgeons will be very happy to see, only to make a decision that I don't need to operate on this patient tomorrow. And the second job of the surgeon in anaplastic thyroid cancer is, how is the airway? Is the airway going to likely to kill the patient tonight or tomorrow?
Right.
If not, we will not do anything.
So would the surgeons do a tracheostomy if a patient comes to us in impending stridor? And you have a diagnosis of ATC, anaplastic.
If the general condition of the patient is good, sir, and if we feel that we might give him some form of treatment later, and if he's in impending stridor and the tracheostomy is relatively straightforward now, I might do it after explaining them the pros and cons of them being living with a tracheostomy ahead. What will be his quality of life and all, and then I might go ahead, sir.
So what is the goals of surgery? You know, the guidelines, ATC guidelines have very beautifully written about what we would want, what we expect and what we need to tell the patient's relatives and the patient of what to expect from this treatment. So before you do the tracheostomy, is there something that you will tell or counsel the patient?
Yes, sir. So counseling about the overall prognosis of the disease is very important. They should know that how bad anaplastic carcinoma is and what will be the overall lifespan we can expect because of this disease. And what are, as I told before, what are their viewpoints, like whether they want to be free from the disease or they want to have a symptom control, palliative symptoms.
Palliation.
Palliation. So, and then depending on that, we have to take a decision. It will be individualized, sir, and there is no set protocol for these tumors. So we have to go by individual.
As far as possible, I feel we should avoid a tracheostomy, try to make the patient more comfortable. Give all supportive care so that the patient is comfortable till you get a diagnosis, if you haven't got the diagnosis, before you head the path of the tracheostomy. So we should have a cross-sectional imaging, we should have a diagnosis. We need to tell the patient that the prognosis is extremely poor. In our situation, even if it's beta positive, we will not have the drug with us, and we would have to depend on other chemotherapeutic drugs, which we have used in the past. So Tasneem, if a patient such like this comes to me, and I admit this patient to give him steroids and oxygen support, what chemotherapeutic drug would you start?
So, sir,
because we don't have all these
yes, sir.
tremetinib.
So chemos are definitely for a patient who will benefit and is hemodynamically unstable, we can think of it. Doxorubicin, docetaxel is the regimen that commonly we go to. If I feel that anthra, elderly patient, not possible, then a taxane with a platin would also not be such a bad idea.
What about lenvatinib? That is available with us.
So, sir, Lenva works beautifully in differentiated thyroid cancers. It will not work here. Don't expect it to work. Now, if a pathologist tells me that there is some component of anaplastic and some cells are differentiated, there I would still, give it a try. But otherwise, not. No.
What
Lenva.
about pembrolizumab?
So, anaplastic is TMB high. They are, but
Can you tell us what is TMB? We are not. We are illiterate as far as all this is
So the mutation burden, if you see thyroid cancers as a spectrum, these are the tumors which will have the highest number of mutations. But if you compare them to other tumors where a higher mutation burden is expected, like a colon, for example, a colon, then still these are low mutation burden cancers. So immuno, again, should not work very well, but we anyway do PDL1, we do a TMB score. If it is high, that is one option to explore.
Because there are some papers which have
Yes,
shown
there
that
are. For pembrolizumab.
Yeah,
There are.
pembrolizumab.
Yes.
PDL1.
PDL1 positive.
So TME stands for tumor microenvironment, just to add.
TME. You're talking about
TMB,
tumor mutation burden.
Tumor mutation burden.
Burden.
Surgeons, forgive.
I just want to make one comment about the prophylactic tracheostomy. 20 years back, that was a common practice, that when the radiation oncologist wants to give radiation therapy, they will be very concerned that middle of the night there will be airway problem, and they will ask you, please do prophylactic tracheostomy. We learned over a period of time that it was not helping the patient, it was hurting the patient. The quality of life was miserable. The tumors invariably grew through the hole that you made, and we were making a mess out of them. They suffered a lot. So when the first guidelines came about 12 years back, we spent a lot of time. We were 4 surgeons. We spent a lot of times offending the prophylactic tracheostomy.
Right.
And I wrote a paper about 20 years back about the role of tracheostomy in anaplastic thyroid cancer, and we kind of condemned it as a treatment choice or approach for patients who are not in acute airway distress. When would I do tracheostomy today? The patient is likely to die tonight with the airway, and the family wants to come from Singapore. They need 48 hours. I'll do the tracheostomy. Because I know the daughter won't be able to see the mother, I will do the tracheostomy. But otherwise, prophylactic tracheostomy is gone. Keep in mind, these patients who have big tumors, when you do the tracheostomy, it is not fun. It's one of the most difficult operations.
Right.
Don't do the tracheostomy unless you have intubated the patient. Otherwise, you will write a death certificate. Don't do the tracheostomy in the emergency room. Do it in the operating room with well intubated, and tell the family that during the intubation process, I might lose the patient.
Right.
And I think they need to be aware about it. That's why our incidence of doing tracheostomies for anaplastic thyroid cancer has gone down. As a matter of fact, with the DAPTAM and Pembro, we rarely need a tracheostomy now.
I think that's a very important point that we need to discuss. Tracheostomy is not without its own problems. So as far as possible, we should try and avoid these. So the next thing is the ones that have gone beyond the thyroid. If you attempt to do thyroidectomy, what happens to the trachea, the larynx, and the esophagus? Would you then consider resecting parts of these or whole if you know that it's an anaplastic thyroid?
I would avoid, sir. Personally, I wouldn't like to keep the surgery as less morbid as possible. And even if it's R1 or R2, we can, generally I would not go for a surgery if I expect that it would be R2. I will directly send them for non-surgical treatment. But if I know I can get away with a R1, I will do R1 and send them for adjuvant treatment. I won't remove these structures.
Will you do a tracheal resection and anastomosis?
No, sir.
Would you do a partial esophagectomy? Would you do a laryngectomy?
If it's anaplastic, none of them.
So these are some organ resections which should be avoided because you know that it's futile in the future. If you are going to avoid a tracheostomy, why would you do these extensive organ resections? So that's a no-no. Only and only if it's an intrathyroidal malignancy and you know that you're going to take it out completely. That's the only case for doing surgery in an anaplastic thyroid. As far as possible, we need to avoid it. And as and when we get these drugs, possibly we'll also head the path of giving neoadjuvant therapy. So these are all the mutations that we see. And apart from the dabrafenib and trametinib, we need to look at the PD-L1s because they are available with us and possibly consider giving them till the time we get these drugs in the country. So this is one paper that we would like you to read, the FAST Multidisciplinary Group Consensus Statement. And this is popularized by MD Anderson, where they looked at the BRAF 600E mutations first and then brought about a protocol which afforded patients a better quality of life, if I may not say just survival. So look up this paper and read these consensus statements. They have given a sort of algorithm for resectable and unresectable and how we need to go about it, just as what we have discussed so far. But their point of contention is the speed at which you need to make the decision. So as Dr. Shah mentioned, it has to be the same day, the next day. Your discussion with the family has to be immediate, and your planning of the treatment has to be with a multidisciplinary team. You cannot make that decision yourself. This is too much of a burden for one individual to take. Please share the responsibility. As Dr. Shah said, it is always easy to spread your responsibility and share it. So going ahead, how do you follow up these patients? Suppose you had these drugs, they talk about adjuvant therapy with the same drugs for a long time. How long would you consider giving it, and what is the outcomes expected, Tasneem?
So if we're using immunotherapy, so as a standard from all the head and neck data we have, I counsel patients for 2 years. That is the counseling. In our setting, beyond 1 year, a lot of people want to stop if they are doing well. Dabrafenib and Tramitin I've never used, so I have absolutely no idea, only theoretical idea I have.
Right. So this is something that they talk about, that you can give it up to a year, but we need to understand the average survival is 5 months. In spite of very good surgery, all these drugs, today you know that your survival is less than 20% are going to make it beyond a year. So all this has to be brought into focus with the patient's relatives, especially in our country where costs will be huge when it comes to these treatment of these patients. So plan your treatment goals before you head the path of actually treating these patients. And should you go the pathway, you need to have a proper plan for getting the finances to treat these patients. Madam, would you give post-operative radiation if Karthik has operated the patient?
In this case, I think post-op radiation along with chemotherapy is the standard of care, and chemotherapy may be either with doxorubicin or with any of the taxanes, I think. Doxorubicin 20 mg per square meter or one of the taxanes.
Not the pembrolizumab or the...
No, sir. So that Pembro data is only for metastatic setting where any local therapy is not going to be possible.
Okay. So we will give a standard of care after your surgery as concurrent chemo radiation, and follow this patient up with local and distant workup. Any questions from the audience? Any thoughts, sir?
Sir, in this paper they have used for all BRAF V600E or
Yes.
Pembro?
Yes.
PDL1 score, did they do it?
So they mentioned that you need to do PDL1, and if it is positive, I guess the CPS should be more than 25 or 20, and then they would use it. But this is a paper worth reading because it is talking about their protocol in terms of outcomes as well.
And how soon would they get a PDL1 result? That's
There is
another
a slight
thing.
difference between MD Anderson and us. The MD Anderson has been using DAP, TRAM and Pembro all along. Now it's difficult if you are using something and it is working to stop that. The memorial does not feel that the Pembro should be added or new.
Exactly, sir. Even I would agree with that.
Yeah. But recently in the ESCO they had a paper, MD Anderson had a paper, that Pembro is more important, showing better results.
But so there's no reason for that to be.
No, I agree with you, but that's why Memorial doesn't use that. Our two medical oncologists who are very up with the anaplastic thyroid cancer, they don't use it.
So it's very clear. We have that concept from lung. If there's a target, you hit the target. There is no reason to add an immuno there. It doesn't make sense in any
You have to
way.
also realize, this is the way they have been practicing for last more than 10, 12 years. They originated this treatment choice. They mastered it. They developed a technique of doing surgery after the targeted therapy. And we have questioned that many times, that if you have no discernible disease, why do you want to operate? Why not just give radiation? And they don't have answer. The problem is you can't do randomized studies on this. You need a huge number. You need to follow these patients. And the science evolves and the philosophies change. When we were developing the second guidelines, there was a lot of discussion about tracheal resection, esophagectomy, laryngectomy, and unanimously we condemned those radical approaches for anaplastic thyroid cancer.
Right.
Whether they are BRAF positive or BRAF negative. I used to use the statement, you might have heard that before, when you operate on anaplastic thyroid cancer, they recur in the recovery room.
Okay. And let the punishment fit the crime. So thank you very much. So I'd like to summarize that these are some of the most aggressive cancers you will come across. The main challenge in a PDTC is the management of distant metastasis. The main challenge in anaplastic thyroid cancer is the rapid control of disease, early diagnosis and appropriate treatment. And the use of IHC in diagnosis of targetable mutations is a key. Multidisciplinary care is mandatory. You cannot do this kind of treatment without a good team. And clear outcome goals and discussion with patient and relatives is important. I would say mandatory. Thank you very much, everybody.
Thank you very much, sir. We thank Dr. Prathamesh Pai, sir, and all the panelists who enriched our minds and imparted knowledge and with the facets of thyroid malignancies. We invite Dr. Roshan Chenoy, ma'am, to give a small token of appreciation to Dr. Prathamesh Pai. We invite Dr. Chenoy ma'am to please give the token of appreciation. We request Dr. Chenoy ma'am to kindly be on the dais. Dr. Asif Mohammed sir. Dr. Archie Agrawal ma'am. Dr. Karthik Krishnan sir. Dr. Ketan Ingle sir. Dr. Tasneem Barmal ma'am.
So I thank you, all the dignitaries. It was a wonderful scientific session. So now it is a time for vote of thanks. So I may call upon Dr. Tasneem Barmal, madam, to offer the vote of thanks. Thank you.
Good evening to all the esteemed faculty, guests, and my colleagues. It was an honor to deliver the closing remarks for today's inspiration meeting. A special thank you to Professor Alok Saha for giving your expertise in thyroid malignancies and enlightening us with practices at your institute. To all the national faculties, organizers, and attendees, thank you for making this event a great success. Let's carry today's knowledge and collaboration to better thyroid cancer care. And thyroid may weigh 20 grams, but today it bore the weight of a lot of heavy discussions. Thank you all and safe travels.